One. We are live.
Good evening, everyone, and I welcome everyone, all the respected faculty, to our second webinar of World Orthopedic Concern Indian edition, Indian section. And this webinar is a collaborative webinar between the WOC Indian chapter and the Asia Pacific Bone and Joint Infection section, along with the European Bone and Joint section of the Indian edition. And I welcome all the respected faculties, and I hand over the welcome address to Professor Arindam Banerjee, who is the president of WOC International and is also the president of World Orthopedic Concern India chapter, and he is the founder and medical director of Medline Nursing Home, and he also is an examiner of Citak diploma and has held various positions in various national associations and in international associations. And without wasting much time, I'll hand over the session to Dr. Arindam Banerjee. Over to you, sir.
Thank you, Vishnu, and thank you for organizing this webinar. And I'm going to start by giving you a welcome from World Orthopaedic Concern International and World Orthopaedic Concern Indian chapter. As you know, WOC International is the humanitarian arm of CECOT. It is dedicated to bridging the gap between the haves and the have-nots in orthopedic surgery. Now, historically, orthopedic surgeons from developed nations donated their time, skills, even their money to developing nations. And WOC used to match the donors with those who had needs. And the local hospitality and airfares were arranged by them through the local the hospital which required expertise from outside. And this has been going on for several years, right from the foundation. Now, after COVID, of course, this assistance has become fairly virtual, but we are trying to organize, again, international fellowships and national fellowships. And I'm sure this will be a reality shortly. The current work of Orthopaedics International, I'd just like to give you an update. We have recently signed a MOU with the Washington-based group called Curvus, who do a lot of work in Africa. Just 2 or 3 days ago, we had a meeting with Surge Hub, which is a big group which is backed by UN and WHO and is based in Geneva. We endorse courses and camps all over the world, and our members link their efforts through us and have a greater outreach. We have been active participants in various programs. We are a sister organization, as I said, of CECOT, but we've also been actively associated with WIOT and Harvard University. This will keep on, these various collaborations will keep on growing. We are also working on creating a virtual museum and orthopedic implants. We're talking about that with a surgeon based in Kentucky. We are also hoping that this implant museum will have a branch in India at some point. As you know, many of us have contributed to a book on orthopedic implants. We have set up an active website which you can access and a newsletter which you find quite interesting. If you haven't received the newsletter, I'm sure Vishnu will make arrangements to send it on to you. Now, this is the current WOC International Executive Council. We have members from all around the world, from India, Egypt, USA, Palestine, Brazil. Also, we have members from WOC UK, WOC Netherlands, also from Belgium, from Nepal, and Professor Taneja is also on our board. He was an ex-president and he is currently continuing as a board member. Several country chapters have been added to WOC recently. The most active WOC chapters are in the UK and Netherlands, and they have independent funds of us. We have their representatives, as I said, on their board, but a lot of new chapters have been added and are being added in Africa, Middle East, and Asia. Recently, we've had the opportunity to revive the Indian chapter. We formed a new board. We've made a new registration as the old one had lapsed. And this new organization, the new name is, for purposes of enrollment, is Empathetic Orthopaedic Concern. The registered office is in Kolkata. But we had to use this name because nowadays in India, if you try to register any organization, you cannot use terms like world or India or Hindustan. That's why we had to use this specific name, but it will continue as World Orthopedic Concern Indian chapter. We are in the process of organizing various teaching webinars and courses, and this is the second webinar we've had this month. We are also organizing courses for paramedical staff. We have two further webinars lined up. I'll give you a list. So a national meet is also being planned in March in Mumbai. We're working on that. And once we have numbers, we will also try to organize a World Congress in India. Now, this is the WOC India Executive Council. You can see here the names. Today we have Dr. Nath, who's our secretary, Dr. Vishnu, who's taken a lot of initiative, and we have several others. I'm sure you're familiar with all these names, and we are represented by various state chapters from India. So we've tried to make it give it a pan-India flavor, and I'm sure we will have a lot of activity. These are just a few pictures. So we had a collaboration with Harvard, and I was invited about last year. I gave a lecture, and that was quite interesting. And they have shown a lot of interest in our work. Similarly, we've participated in WIOT in Cairo, and then subsequently in Kuala Lumpur, the Kuala Lumpur SICOT, as well as in the Cairo SICOT. And we have several home-grown programs as well. We've had PG instructional courses in Indore, and we had a course for operational theater technique, again in Indore. Then we've had a straight, we've had, with the help of we've had a third Calcutta Spine Deformity Conference. This is under the aegis of Operation Straight Spine, being organized regularly by Dr. Ujjwal Devnath, but we are one of the collaborators of this program. Our ex-president, Dr. Ala, comes every year as faculty. Recent activities include low back pain webinar organized by Dr. Chinmay Nath, who is here today, on which we had 4,000 live hits. This was also on Ortho TV. Then we've just recently had a program with SICOT Pioneer, where Dr. Sasinder took the initiative. Dr. Sasinder is currently the Education Committee Chair in SICOT, and we all participated. This is the third program. There's another program on the 3rd of August being organized by Dr. Sasinder, and that will be again with knee pain. As I said, we are trying to do an annual face-to-face meeting in Mumbai, and we'll keep you posted about that. Dr. Satish Muta, who is also on our board, is taking the initiative for the program in Mumbai. We will keep you posted on all the activities. If you wish to join our WOC India chapter, please contact Dr. Vishnu or Dr. Sasinder or Dr. Chinmay Nath, and they will have you enrolled as a member. The fees are 5,000 rupees, and we will be opening the international membership very soon. We had some bank details to work out. That's all being done, and we are looking forward to having you all as national and international members, so that you can collaborate and participate in all our programs, as well as allow us to participate in the programs which you do in other organizations. So with that, I finish my welcome talk, and I'm stopping my share here, and I will now go on to the main webinar, the main lecture.
Sir, can I just introduce the faculty, sir? I'll share the screen and just introduce once.
Yeah, sure.
So today for our webinar on recent advances in musculoskeletal infections, we have our two international faculty. The first one is Professor Dr. Mustafa Citak, who is a senior consultant orthopedic surgeon and director of research from Helios Endo Klinik, Hamburg, and he is a very pioneer work in musculoskeletal prosthetic joint infections in TKR, and he has done various important work, and he has around 251 indexed articles in Medline, PubMed, and Scopus. He was a recipient of the prestigious travel grant Galaxo Smith Kleinstip International Society from the Isaacos Fellowships, and he is a winner of multiple societal awards and fellowships. And our next international faculty is Dr. Haesham Elbasset. He is a lecturer in orthopedic and trauma surgery from the Pediatric Orthopedic Unit, Assiut, Egypt, and is also a member of the Citak Young Surgeons Forum, and is a very young active member in pediatric surgery, pediatric hip, and he is organizing various programs, international and worldwide. And coming to our national faculty, I already introduced Dr. Arindam Banerjee, who is the president of the World Orthopaedic Concern and the Indian chapter. And next is Dr. Chinmay Nath, who is our secretary of the World Orthopaedic Concern Indian chapter, and is a consultant orthopedic and spine surgeon from the Apollo Multi-Specialty Hospital, Kolkata, and is also an associate professor in JS School of Medical Science College, Howrah, and he is also a member of the various positions held in the West Bengal Orthopedic Society. And coming to our national faculty, Dr. Vikas Agashe, who needs no introduction, and sir is a pioneer in musculoskeletal infection, and he has a long teaching career, and sir is from Consultant Orthopedic Hospital, Hinduja Hospital, and he has presented various lectures, and his pioneer work in musculoskeletal infection has constant involvement in various international organizations like the AO and other organizations. Coming to our Aditya Menon, was a young dynamic orthopedic surgeon and was very instrumental in organizing and this webinar for having this collaboration with two international associations, the Asia Pacific Infection Section and the European Bone and Joint Network. He is also a musculoskeletal infectious specialist from and is also orthopedic surgeon from the Hinduja Hospital, and is also an honorary secretary of the infectious section of the APOA, and he is a country delegate for the European Bone and Joint Infectious section, and is also faculty of various international and national conferences and societies. And coming to our final speaker, who is an infectious disease specialist, Dr. Umang Agarwal is a general medicine, and he has done a F&B in infectious diseases, and he is a mentor for various infectious disease program and F&B program, and he is a coordinator for the antimicrobial steward committee of the Hinduja Hospital, and he is a very key member in the infection hospital council of the Hinduja Hospital, and he has nearly around 31 index publications in pertaining to the joint infections also. Now, thank you for everyone for joining this today webinar, and I go to our first speaker, Dr. Arindam Banerjee, and over to you, sir. I'll just stop sharing.
Okay, thank you, Vishnu, again, and let me do the slideshow. Okay, is it visible?
Yes, sir.
Okay, good. So today I'm going to be talking about the basic sciences, and this talk is going to be really quite basic. We're going to set the platform for further discussions because, you know, as I said, I'm an examiner of Citak diploma, and we find that, you know, while people know a lot of the recent advances, we don't think about the basics like what infection is and what are the basics of infection. So I'm going to start with a definition. The invasion of an organism's body tissues by disease-causing agents and their multiplication, as well as the reaction by the host to these organisms and their toxins that the organisms produce and the reaction of the host, that is an infection. An infection can be latent, it may not cause symptoms, or it can be symptomatic. Now, fundamentally, there are 4 types of infections. One is viral. In musculoskeletal tissues, it can cause acute onset polyarthritis. We can have bacterial infections. We can have pyogenic infections, which are gram positive or gram negative. We can have mycobacterium infections, which may cause tuberculosis and other such things, such as leprosy as well. We can have parasitic infections, such as hydrotic cyst of the bone, or fungal diseases, such as Madura mycosis. Now, musculoskeletal infections are quite common. We can classify them as superficial. Superficial infections would be cellulitis, infective tenosynovitis, biomyositis, soft tissue abscesses, and then of course they can be deep. They can be things like infection of the joint, septic arthritis, acute, subacute, and chronic osteomyelitis, and of course what is becoming very common nowadays, post-operative implant infections. There are 3 routes of spread of musculoskeletal infections are hematogenous, which is blood-borne. It can be due to direct implantation, and it can be due to direct spread. Now, hematogenous is indirect, but it is in fact the most common, and it happens when the portal of entry is different from where the actual disease happens. So it spreads by blood. It can be a direct implantation, and that the most common type of infection in this case would be from implants which get infected. And direct spread can happen very commonly in diabetic and in paralyzed patients where contiguous spread is important. Now, bacteria can be described on the basis of the shape or the type of colony we have. So we can have coccus, which are really round bodies, and they're usually in clusters, or you can have them in chains, the streptococci, round bodies in chains. And occasionally, like in pneumonia, you have diplococci, you have 2 round bodies together. Then there are the longer ones. These are usually gram-negative, the bacillus. You can also have Clostridia, which is sort of drum-shaped type. Then the Vibrious, which can cause things like cholera. Spirilla, which can cause Lyme's disease. Micrococci, which also causes various types of pathological problems like peritonitis, etc. And spirochetes, which can cause syphilis, which is becoming quite uncommon. It's becoming quite uncommon to see syphilis in bone nowadays, but there are pockets in the world where sexually transmitted diseases are still very common, especially because of the AIDS epidemic which has happened in parts of the world. So let's start with gram-positive and gram-negative organisms. And these actually are different because of the cell wall they have. So you can see here the cell wall of a gram-positive organism. And here there is a lot of peptidoglycans. And this is important because this kind of cell wall is, when we plan to eradicate these organisms, we try to take advantage of this thick cell wall. Whereas in the gram-negative organisms, the cell wall is made from lipoprotein. So it's not so easy. It's not a very thick wall, and we can't take advantage of that. So gram-positive organisms, which are much more common in musculoskeletal diseases, cause cellulitis, abscess, osteomyelitis, and is commonly due to Staphylococcus aureus, Streptococcus, and they can also cause toxin shock syndrome. In addition, things like MRSA are also in this group. Gram-negative infections, they're not that common in musculoskeletal regions. Things like salmonella, typhoid, pneumonia from Diplococcus, UTI from various things, bacterial meningitis, and gonorrhea. But of course, they can cause musculoskeletal problems as well. We can get bad cases of E. coli in bone as well. So, I mean, both of them affected, but gram-positive infections are easier to treat. Because it's easier to treat because the cell wall of the gram-positive bacteria absorbs the antibiotics and the cleaning products we put in. So therefore, if we can target the cell wall of a gram-positive bacteria, we can knock it out at the onset. And that's why it's very important that we have to make sure that the cellulitis, abscesses, etc. are treated early so that they don't end up becoming osteomyelitis, which is very difficult to treat. Now, I thought I'd just give a, for students hearing this and postgraduate trainees, just a little bit, just the concept of gram-positive staining. So first, the bacteria, we just touch the agar colony, and we don't really scrape it. We just barely touch it, and then we put the bacteria, we slightly fix it on the slide, and then we add crystal violet, which gives it a sort of a purple color. And then we add iodine to it, which reacts with the crystal violet and it becomes an orangey color. Now, we try to decolorize it with 95% ethyl alcohol, and that kind of takes away the cell wall color of gram-negative organisms, but it doesn't take away the color from the gram-positive organisms. Now, on this note, I want to make a point that, look here, this is only 5 to 10 seconds. If you were to put the ethyl alcohol and keep it there for 2 minutes, then everything would become gram-negative. So it's important that the ethyl alcohol is not put for very long. And after that, color saffronin is used as a counter stain. And then you have these gram-negative bacillus, and you have the gram-positive cocci, or either the staphylococcus or the streptococcus. Now, this is Mycobacterium tuberculosis, and we have to talk a little bit about Ziel-Nielsen staining as well. This is what the organism looks like, and this is what the slide looks like when you have a Mycobacterium. Now, to diagnose TB, it's not always easy. We have to sort of think about all the aspects. First thing is that we need to have a clinical diagnosis, and after we have a clinical diagnosis, we have to look for evidence of Mycobacterium tuberculosis. If we were to find Mycobacterium tuberculosis, that is a definitive proof that tuberculosis exists. This can be from a culture of sputum or bronchial alveolar lavage or lavage of the gastrointestinal tract, pleural fluid, or it could be from even a biopsy from the pleura or the lung. After this, after we sort of get our sample, the sputum or whatever, we have to try and do a culture. We do a smear. We also do a test called Mantoux, which we all know. Usually in India, we would do a 1 in 5 TU. And this actually checks the cell-mediated immune response of the host. And on that basis, we can come to a conclusion whether our patient has tuberculosis. But tuberculosis is not that easy to pick up. So often we have to do tests which are more complicated. So we have various types of genetic tests, the CB-NAT, which is now a sort of a gold standard. And it is actually cartridge based, so it's easy for nurses to do in remote areas. And it is really a more sophisticated version of the gene expert test, which we used to do in the past. This again is done from sputum, from various types of lavage, pus, etc. It's important to remember, again, a point I would like to make is that we don't use stool, urine, or blood. So if you wanted to do a blood test, then there is another test called interferon gamma release assay. I'm not an expert on this, but this is what is normally done if we want to detect it in blood, because the serology ELISA tests are pretty inconsistent, inaccurate. In some cases, they're oversensitive. So it's difficult to do this, to be sure whether a person has tuberculosis. So the CB-NAT and the interferon gamma release assay, these are the things currently in vogue. Now, it's also important, there are some basic tests which we must not forget. One is the blood picture, things like lymphocytosis, which is not always there, and a high ESR. It's important to remember that CRP is not that important. ESR is more important when we're trying to make a diagnosis of tuberculosis. And of course, if everything else fails, you can do a clinical trial of anti-tuberculous drugs, and we've done this in the past with good results. So this is how the acid fast bacilli are tested. So hot carbofushkin is put on the bacteria, and then again decolorization with alcohol, and then counter staining with methyl blue. And here you are then left with, if you are lucky, with AFB bacteria. Now, let's talk a little bit about pharmacology. So, we all know that bacterial and tuberculous infections are treated with antibiotic, but what is an antibiotic? It's important that if we want to be very fussy, we have to think that antibiotics are not, generally when we say antibiotics, we mean everything nowadays, but basically antibiotics are chemical substances which are usually produced by living organisms. So it's generally a microorganism which produces a substance in order to retard other microorganisms. And if we can sort of find this, if we can purify the product, then we are left with an antibiotic such as penicillin, or cephalosporin, or streptomycin, etc. Now, the other things which we call antibiotics, they can be divided into two groups, synthetic or semi-synthetic, and they also act against microorganisms, but it's called antimicrobial chemotherapy. So there's a subtle difference. This I remember they used to ask this at MBBS level if someone is taking an exam. This is an important point. And if you're dealing with synthetic or semi-synthetic antibiotics, and you're talking about ampicillin, which is semi-synthetic, and say a quinoline, which is synthetic. Antibiotics can also be classified as broad spectrum, such as doxycycline, which act again against a lot of organisms, or a narrow spectrum, such as gentamicin, which acts against specific organisms. They can be bacteriostatic, by which I mean they keep the bacteria in check, and then the body responds, cleans up the infection. These could be things like tetracycline chloramphenicol, or the antibiotic can be bactericidal, where they kill the organisms, such as penicillin. Penicillin, for instance, if you were to give it in syphilis, it works very well. It just kills the bacteria. So these are the chemical classes of antibiotics based on chemical structure, things like penicillin, aminoglycosides, cephalosporins, macrolides, tetracycline, etc. Now, coming to drugs used in TB disease, you have the first line, usually rifampicin, isoniazid, pyrazinamide, ethambutol. We have all used streptomycin in our careers, but I guess streptomycin has some toxicity, so perhaps nowadays people think of it more as a second-line drug. But it's important to remember that we sometimes use 4-drug regimes, sometimes we use 3-drug regimes, and they're all given simultaneously in order to prevent bacterial resistance. Some of the second-line drugs are like kanamycin are not being used in USA, but there are quite a few like amikacin, levofloxacin, moxifloxacin, gatifloxacin, which we use in other diseases, but are quite useful here. And of course, if you have a very bad TB, multi-drug resistant TB, then you have these 3 drugs such as linezolid, etc., where you can try to use them and try to get rid of the disease. Now, any basic talk on musculoskeletal infections would not be complete unless you talk a little bit about osteomyelitis. I don't want to go into too much detail because all of us have dealt with osteomyelitis at some point in our careers. Just the basics again. Osteo means bone, myelo means marrow, and itis is inflammation, as you know. So osteomyelitis is basically infection of the bony cortex as well as the marrow and the surrounding soft tissue. So that's an important point. This osteomyelitis can be direct when it develops from a skin puncture or from an open fracture or surgical operation, implantation of orthopedic implants, etc. Or it can be indirect when the infection is bloodborne, hemogeneous, and infects the site quite different from the portal of entry. Now, there are some interesting additional facts which we have to know about, that in the pre-antibiotic era, 25% of patients with osteomyelitis did not survive. And there is still a lot of morbidity and disability worldwide, especially in depressed areas of the world, which is due to lack of access to care. And I was surprised to hear that it is a leading cause of amputations in USA. And I think this is mainly in drug addicts, in the very elderly and frail population, in HIV patients and patients who have lots of comorbidities. It also causes a lot of pediatric disability worldwide. And as you know, chronic osteomyelitis is very difficult to eradicate completely. So the classification, very simple: acute, subacute, and chronic, and it depends on the nature, virulence, dose of infecting organism, the age, immune response, the general condition of the host, and the role of the antimicrobials which we are using. Now, on this point, I want to just draw your attention to another very basic facet, that acute osteomyelitis can turn into chronic, but acute osteomyelitis is fundamentally quite a different disease from chronic osteomyelitis. So the first thing to remember is that acute osteomyelitis almost, in most cases, happens in children. This is something we need to focus on. So the child may be quite sick, have fever, holding the limb still. There may be local redness, swelling, warmth, and edema. There may be non-specific lymphadenopathy. Now, sometimes the features may be such that you may not be able to pick up the disease, and the child may present with failure to thrive, irritability, and drowsiness. And also, these features may be also modified by the inadequate use of antibiotics or the abuse of antibiotics, and this may lead to us not picking this up. But it's very important, because once this child gets acute osteomyelitis, this later may become chronic osteomyelitis, and that can become a major issue for the child, for that adult later on. Now, the other thing to remember is that it happens in a metaphysis, and that is mainly because of the hairpin loops like this. So here's where the nutrient arteries are doing their hairpins, and because there is stasis of blood here, it can lead to deposition of bacteria, which leads on to problems with the metaphysis. Another issue in the child is the growth plate, which actually acts as a barrier, and it prevents, sometimes it might prevent septic arthritis, but it's important to remember that the growth plate is only strong in older children and not in babies. So babies might go on to develop septic arthritis, which you might see in a very young children. They have hip problems. That's because their growth plates are not that developed at that point, but a younger child will probably present with osteomyelitis. So difficult to pick up osteomyelitis, but again, it's a very basic thing. We mustn't miss it. We need to think of other things we are confusing it with, like neoplasms in childhood, osteosarcoma, even sarcoma, fractures in anesthetic limbs, such as in a spina bifida, JRA, juvenile rheumatoid arthritis, which I think is a underdiagnosed conditions, and things like septic arthritis and cellulitis. So the pathophysiology is here. Over here, I won't spend too much time. And over here, development of osteomyelitis, which happens after if the disease, we cannot get rid of the disease early on, then it goes on to form sequestrum, which is dead bone, and that involucrum, which is new bone formation, also forms. Once the sequestrum is formed, then it becomes chronic osteomyelitis, and it becomes very difficult to get rid of it medically, and then we have to do some kind of a surgery. Now, the other condition which we need to know about is post-traumatic osteomyelitis, open fractures with contaminated wounds, which are a combination of tissue injury, vascular damage, hematoma, edema, etc. Clinical features are pain and fever and swelling over the fracture site. So open fractures here, grade 1 to grade 4, which can always lead to osteomyelitis. This is another thing, implants, infected implants, these can lead to osteomyelitis. These are the commoner cause of osteomyelitis nowadays. So the predisposing factors of the infected implant: soft tissue damage, bone death, poor contact between the bone and the implant, loosening of the implant, corrosion, infected cement, and patient factors such as poor host defensives. So we need to prevent post-op osteomyelitis, and in this case, prevention is better than cure. So we have to avoid doing too many operations on the immunocompromised, eliminate the septic focus, achieve perfect sterility in our OT. We have to give prophylactic antibiotics at induction, high quality, well-designed implants. We have to do the surgery well with the implants secure properly on the bone, and avoid intercurrent infections like UTI. So this is, you can see the picture between healthy bone and and the difference between healthy bone and osteomyelitis. And this is what a chronic osteomyelitis sequestrum looks like. I'm sure all of you have seen it in your practice. So I come to my take-home message for musculoskeletal diseases, and I've concentrated today on the basic sciences because it will set the platform. The infection of musculoskeletal infections have fallen worldwide. It was a major problem when we were residents. We don't see that kind of those problems nowadays, but there's also the current infections are more in the immunocompromised because we have to treat conditions like MRSA, multi drug resistance TB, HIV, and sometimes HIV and TB come together. Our diagnosis is based on clinical features, lab-based tests, or could be radiological. Currently, we have many effective antibiotics available. The antibiotics are effective if we use them properly and if we don't abuse them. And even if we do everything, there are some bacteria which are difficult to treat, and there is, of course, a group of TB which are still a challenge. So with this, I end my talk, and I hope we can all think about the basics whenever we do the high-flying stuff. I think it's also good to basically know what is a gram stain, how a TB diagnosis is done, etc. Thank you very much.
Thank you, sir, for an elaborative talk on the basic sciences of musculoskeletal infections. Next, I will go to Dr. Umang Agarwal, who will talk on optimizing diagnostics and therapeutics in 2024. Over to you, Dr. Umang. Please unmute yourself.
Okay. Apologies for that. At the outset, I would like to thank the organizing committee, Dr. Vishnu and Dr. Aditya, for kindly inviting me for this particular talk. So I was basically asked to talk about optimizing diagnostics and therapeutics in 2024. And the background picture really says it all. The entire point is to fine-tune your approach to optimize patient management. And that is the basic theme that I'll be speaking about next in the next few slides. Just hold on. Yeah. So I'll be talking a bit about bacterial infections and something about mycobacterial infections given the shortage of time. This entire topic itself can actually take an entire webinar just to focus on this, but given the 15 minutes, I'll be very brief. So let's start with the case. We have a 92-year-old lady who has lots of comorbidity. She has chronic obstructive pulmonary disease, ischemic heart disease. She had undergone apologies, that was a right-sided TKR. It's by mistake written left. She had undergone a right-sided TKR 3 years ago, had recurrent UTIs, taken several antibiotics, and was now admitted with right-sided knee pain, where the TKR had happened around 2 months. MRI was done, which showed the presence of collections, sinus formation, so essentially a prosthetic joint infection, and she was admitted with us for further management. On examination, her pulse was okay, blood pressure was 110 systolic. However, she was a bit low towards her saturation. A moribund, not really moving around much, poor mobility. She was quite obese as well. Her weight was around 110 kgs. By and large, the systemic examination was within normal limits. The initial labs showed a WBC count of 14,200, a CRP of 120, creat was 1.8, so she was having AKI as well, a procalcitonin of 3.2, and an ultrasound showed a collection over the right knee. Now, obviously, the ideal thing to do would have been a 2-stage revision in her case, given her findings and everything else. However, she was surgically deemed unfit, predominantly because she was 92 years old, had lots and lots of comorbidities, had concerns about recurrent UTIs, but that was not much of a concern. Possibly it was the bug that had actually gone and seeded that particular joint. But we also know that this patient was on several antibiotics at that particular point of time. So eventually, the surgical team decided that they wouldn't operate. They will try to conserve and manage medically as much as possible. And that is when we were called in. So we requested for a joint aspiration. Interestingly, all the cultures came negative. But that is when we ordered this biomeru test known as a joint infection biofio, which is basically a rapid PCR comprising 39 targets. And this information is available within a couple of hours of the test being run. And this is what it showed. It showed the presence of Klebsiella pneumoniae, which was the bug. And it showed NDM and OXA48 as the mechanisms of carbapenem resistance. So basically, these two are enzymes which cause carbapenem resistance. So within a couple of hours of joint aspiration, I knew that this particular patient has a carbapenem-resistant Klebsiella pneumonia infection of the tooth, despite the cultures being negative. And that is the beauty of rapid tests. The patient was commenced on ceftazidime, avibactam, and astronam. I'm not sure how many of you all really deal with carbapenem-resistant bugs in your setting, but in our setting, which is a tertiary referral center for the most complex bone and joint infections, this is something that we see not unoften, kind of a thing. And ceftazidime, avibactam, and astronam is the ideal drug combination for this kind of a bug. Why I really bought this case and this particular situation in front of you was to tell you about the joint infection by fire. It has several targets. I'm not going to go into the details of that, but it shows lots of gram-negative bacteria, most of them being relevant in our setting, gram-positive, including the anaerobes, which are generally not easy to grow on culture. You can also get yeast, but not all of them. And of course, important resistance genes. So these carbapenemases, these are the enzymes which cause carbapenem resistance. ESBL, CTXM makes the bug susceptible only to carbapenems. It can detect MRSA. It can also detect resistant enterococcal infections. So while this particular target detects a lot, but it does not detect everything, that is a very important take-home message. Yeah. So even if your biofire is negative, does not mean that you're not dealing with an infection. And just to elaborate this fact, I'll just tell you a bit about our experience. This data was taken from Dr. Menon's study, which I think he's presenting that in EBGIS, and eventually he'll be publishing it. So there were 54 patients, 54 patients with bone and joint infection and skin and soft tissue infections, which were retrospectively studied. Pathogen identification by the joint infection panel was found in around 42 patients, that is around 72%, while that by cultures was in 50 patients out of 54. This was quite surprising because we expected the GI panel to do relatively well, but when we actually looked more closely as to why this particular panel did not perform that well, the major concern was that we do get a lot of non-tuberculous mycobacterial infection in our settings, and the target for NTM is not present on a GI panel. So that is a big, big concern. Moreover, pertaining to the mechanisms of resistance, while it detects carbapenem resistance against Escherichia as well as Klebsiella quite well, it does not do so well pertaining to Pseudomonas and Acinetobacter if it's a carbapenem resistant bug, predominantly because those targets are not present in this particular panel. You also need to understand that this panel has been devised actually more to keep in with the European setting or the American setting, not really the South Asia Pacific setting, where our epidemiology is very different. But this is the best we have to date. The failure rate, that is an on-panel pathogen not detected, for instance, if it was Staphylococcus aureus. So the panel failed to detect that. That happened only in 2 such instances. So the failure rate was not very high. So this is what I would talk about, that this is one particular panel that is available for commercial use. And in our practice, we have found its true utility in patients who have been exposed to antibiotics already, which will be the case in most of the tertiary centers. They have gone all across the city looking for the solution for their problem, wherein antibiotics have been given right, left, and center. And eventually, when they come to you, you try getting cultures done, they are never positive. It facilitates early targeted interventions, and this was especially important in the lady that we discussed because we really did not have much time to wait given her age, comorbidities, and the amount of collection that was there inside. And of course, it is antimicrobial stewardship as well. So with this in mind, let's put on to the second case, something that Dr. Arindam has already discussed. While he spoke about the basics, I'll be going a bit more into the diagnostics and where we are at with TB treatment today. So we have a 23-year-old girl who had come in with fever, weight loss, loss of appetite for 2 months, along with gradually progressive left knee pain for 3 months. There was no history of trauma. The MRI showed a left knee collection and an ultrasound guided aspiration was done, which showed tuberculosis. So whenever we talk about TB diagnostics, the usual tests that we order are TB culture, AFB smear, expert, or in certain centers, expert ultra. And of course, we talk about the histopath. For the want of time, my talk is going to focus more on the molecular tests. So expert ultra, along with the advanced ones that are available right now. So we know that. So I'll just talk a brief about TB culture. We know it's a gold standard, but the major problem is that you get these results only after 4 to 6 weeks, which is a big problem in our setting. When we compare AFB smear with expert and expert ultra, so if I may, this is the AFB smear, which Dr. Arindam had spoken about as well, with the AFB positive bacilli seen here. This is the expert cartridge, and this is the expert ultra cartridge. If you look at the sensitivity of these tests to diagnose TB, for an AFB smear to be positive, you require at least 10,000 bacilli per microliter to be positive. So if you have 5,000 bacilli in that particular smear, the AFB smear will be reported as negative. The same thing for expert, you just require 131 bacilli, while for expert ultra, you require 16 bacilli. So you can absolutely understand that expert ultra by and large wins the game, having the highest sensitivity amongst all these tests available. So while it is an excellent test, the major concern about both expert as well as expert ultra is that it can only detect rifampicin resistance. But is that really enough for a setting like ours? Well, in a setting like Mumbai, if you talk about, I would say that detection of rifampicin susceptibility is not enough. And this would probably hold true in most of the settings across our region in Asia Pacific, where drug resistance is a major issue. If I just tell you the data, this was a data that was published in 2015. So that is around 10 years back, which showed that the prevalence of pre-XDR TB, that is MDR plus, a step higher than multi-drug resistance. So the prevalence of pre-XDR was higher than MDR. And this is the kind of resistance that we are really talking about in our setting. So it's imperative that we understand what kind of bugs we are dealing with. Moreover, at least in a setting like Mumbai, the initial prevalence of isoniazid monoresistance, wherein all the other drugs are susceptible, but isoniazid is not. That particular prevalence was expected to be 5 to 10%. But over the past couple of years, the same prevalence has gone up to 20 to 25%. This is our data that we are talking about. Of course, it could be skewed because we do see we are one of the most referred tertiary centers for TB. But even if your gene expert shows rifampicin susceptible, does not mean that that particular bug is isoniazid susceptible as well. So if you are treating it only on the basis of gene expert report, you will be wrong in around 20, you'll be wrong in around 20 to 25% of your patients, at least in a setting like Mumbai. Probably in a setting like Kolkata or maybe in other centers across India where drug resistance is not a problem, this might not be so much of an issue. So for us, molecular diagnostics become all the more relevant, and these are the ones that are currently available in our setting. I'll be focusing my talk on expert XDR and pyrosequencing. Well, while pyrosequencing may not be available in all centers across India, expert XDR is something that is available and can be easily bought into your system. And what are these tests? So by and large, both these particular tests talk about sequencing and detection of additional drug resistance. Expert XDR is an add-on test. So if your expert ultra shows rifampicin resistance, then in that case, expert XDR can give you information on isoniazid, quinolone, aminoglycosides, and ethionamide as well. All right, same as given by pyrosequencing. However, Expert XDR is relatively less sensitive to pyrosequencing. If you compare Expert XDR compared to Expert Ultra, so the turnaround time is the same, the cost is the same, and you don't require any technical expertise. All right. So this is a very, very useful add-on test, which is not expensive. It is actually, so the government of India is actually trying to roll this out as a reflex test for TB across government centers as well. So that is where we are at pertaining to TB diagnostics. So once the diagnostics are done, let's look a bit into the therapeutics. So this is the prescription that was prescribed for this patient. This is a 60 kg woman for whom isoniazid was given at 5 milligrams per kg, that is 300 milligrams. Rifampicin at 10 mg per kg, that is 600. PZ at 25 milligrams per kg, that is total 1500. And Thambutol at around 1 gram HS. Is this prescription in the present setting appropriate? So that is the question that comes into play. And why this question comes into play is because we have seen clinical failures even on this prescription, which is the one recommended by the government as well as by the WHO at present. We did a very small study of around 50 patients. And if you just look at the title, standard dosing was associated with subtherapeutic levels and poor clinical response. When I actually quantitate this, with a standard dosing, subtherapeutic isoniazid levels were found in 36% of the patients. Subtherapeutic rifampicin levels were found in more than half the patients, while delayed recovery at 2 months was found in almost half the patients with the standard dosing of the TB drugs that we're using right now. Agreed that it's a small study, but it is a bit of an eye-opener. This particular study was done by a Department of Biochemistry. To further add on the study, they collected more data and found that with the standard dosing recommended, only 18% of the patients actually had isoniazid and rifampicin in the therapeutic range. All right. 88 out of 125 patients were using fixed drug combinations. And why is this particular point relevant? I'll be talking to you about this in some time. More importantly, with the recommended regimen, 38% of the patients actually showed a suboptimal response, while 5% of the patients developed drug resistance during treatment. This is the standard dosing that we're using now, and this is what we are seeing in 125 patients that we studied at Hindu. Extrapolate that to the entire country and imagine what numbers are and what is really going on in our particular setting. And now, what is the basis of all this? Why does this really happen? So in a patient, there is something known as an acetylator status in the patient. And this particular acetylator status determines the metabolism of isoniazid. Right? We're just going to go a bit deep into this. So a patient who is a rapid acetylator will metabolize the isoniazid more, as a result of which the levels of isoniazid would be low, which is actually seen in this particular graph on the right. So if you're a rapid acetylator, you will have low levels, while if you are a slow acetylator, you will have high levels. Conversely, however, it was found that the rifampicin levels follow this particular logistic in a different way, in a very opposite way. And the reason for this is because isoniazid inhibits the bioavailability of rifampicin. Just to reiterate this fact, this particular study was done elsewhere. And these are all the rifampicin levels, the one in blue as well as the one in yellow. The initial levels, the one in blues, are the ones when isoniazid and rifampicin have been given as a combination. So these were the blue bars that are seen, the rifampicin levels that are seen. If you just split the doses and you give rifampicin in the morning and isoniazid in the afternoon, look at the levels of rifampicin that are now achieved in yellow. They go up significantly higher. So a simple maneuver of not using arsenics, but using rifampicin separately and isoniazid separately can tremendously increase the levels of rifampicin in your particular patient, equating to better drug efficacy. Not only that, they also say that the dose of 10 milligrams per kg of rifampicin is probably an underdose. And if you actually look at the literature, there are several studies that show that higher doses of rifampicin would produce a better clinical efficacy. And now this particular study has been published in March 2024 in one of the most reputed infectious diseases journals. And this study is from India across 6 centers, and it's a randomized control trial. So this is the highest evidence that you can get, wherein the authors found that a dosing of 25 milligrams per kg of rifampicin has a higher efficacy with the similar toxicity profile compared to 10 milligrams per kg. Yeah. So these are the new things that have come up in therapeutics and diagnostics for TB. And if I just need to sum this particular talk altogether, definitely neurodiagnostics help in selective situations, undoubtedly. We should avoid the use of fixed drug combinations if we are treating TB. Please split the dose of isoniazid and rifampicin. The dossier formulation that is generally provided by the government, that is something that we should not really follow. And of course, a higher dose of rifampicin is the one preferable. WHO is actually looking into this data, and probably the next guideline would recommend a higher dose of rifampicin. I'm not sure whether they would recommend 25 mg per kg, but it's possible that it might recommend at least 12 or 15 milligrams per kg. Thank you.
Thank you, Dr. Umang. It was such an insightful this on newer therapeutic diagnostics. So next I'll go to Dr. Aditya Menon, who will talk on WBC PET-CT, the new gizmo in musculoskeletal infections. Over to you, Dr. Aditya.
Thank you. Thank you, Dr. Vishnu. And thank you to WOC India, Dr. Banerjee, Dr. Chinmay, Nath, Dr. Vishnu for having all of us here and having this very unique session on recent advances on bone infections. It's a mix of basics and advanced, so that's how I chose this topic. It's a relatively new kid on the block as far as technology in orthopedic infections, bone infections is concerned. It's a little advanced from the PET-CT that we generally are used to seeing either in metastatic tumors or infections, and this has gone a little ahead beyond that. And this talk is the work of the nuclear medicine department headed by Dr. Natasha Singh at Hinduja, Agashe sir, myself, and obviously the ID and micro teams are always there. It's a team that manages all these cases. So what I'll be restricting on in these cases is what we have found, and I will not be completing the entire story for want of time. So we'll see where this new investigation fits in as far as musculoskeletal infections are concerned. So going back to a little basic, why do we need imaging in infections? I think we need to know whether there is some infection, yes or no, and as close to the truth as possible. And if there is an infection, how extensive is it? We need to know whether it's soft tissue involvement, what's the articular status, what about the implant of processes, bone quality. So we use multiple things. We use X-rays, we use MRI, CTs, and maybe if possible, we use these new tests called PET-CTs or leukocyte PET-CTs. End of the day, what we need to know is whether there's any soft tissue infection around the processes in a PGI, in a total hip or a total knee. We want to know, in a total hip, we want to know what's behind the acetabulum, what's happening in the medullary canal, if there's an infection there. Similarly, in a fracture fixation, again, it's soft tissues. If it's a helical blade in a proximal femoral cephalomedullary nail that we commonly use, has the infection gone into the femoral head, because that changes the treatment protocol. And what about the medullary canal again? So if any test or investigation can tell us with almost near certainty that these areas are involved, then it would really help us go a long way in deciding whether we can salvage a prosthesis or a fixation, or we'll have to take out that implant. X-rays do give us information, and that's the first step. But I think by the time they give us concrete evidence, infections already set in a big way, and things have prolonged quite a bit. MRIs are the gold standard, but unfortunately with implants, with processes, even with metal artifact reduction sequences, we do see a lot of artifacts. Good radiologists will still be able to tell us whether there's evidence of PJI or FRI or not. But by and large, they are very restricted by the limitations of the technology. And that's when a lot of new tests started coming in a couple of decades back. You had these leukocyte scans, which were technetium labeled. They were good, but at the same time, the imaging resolution was not good. They were extremely time consuming, and they fell by the wayside eventually. And then came in the PET-CTs, which we all know is used in tumors and cancers, but they were also used in infections. But they improved the they improved the imaging quality, and the artifacts were less, but they could not differentiate between aseptic versus septic. early postoperative infection was a very big limitation to know whether it's post-op inflammation or actual infection. Again, in some cases, neoplastic versus infection could not be differentiated. So it was not very specific. So the nuclear medicine world decided, okay, let's try and get the best of both worlds. So they take a little bit of blood from the patient, get the leukocytes from it or the WBCs from it. They tag it with FDG and then inject it back into the patient, and then it goes through the entire body, the liver, spleen, bone marrow. And the theory behind it is these tagged WBCs get attracted to the infected area. And if it's the focus of infection, more WBCs or leukocytes will go there. And this will give a higher uptake. And that will tell us whether there's an infection or not. So it's specific for infections. It can, or it's supposed to differentiate early infection from postoperative inflammation. And it gives images with excellent resolution. So theoretically, where they have placed this test is for peripheral bone osteomyelitis, periprosthetic joint infections, diabetic foot infections, and skull-based osteomyelitis. The limitation, and we all need to understand that if we have this test available, is it has no role in chronic infections or spondylodiscitis or vertebral osteomyelitis, simply because they're more chronic inflammation. And in vertebral and spondylodiscitis, the blood supply is so low that the leukocytes really don't reach that area. So we started using this test once it became available. It's been a learning curve for all of us, Agashe sir, myself. And what we did was we did a series of cases. It's an ongoing thing. And we've gone back and seen what is the correlation between what the PET-CT says, or the leukocyte PET-CT tells us, okay, this is the area of increased uptake. Does that really match with what we found during surgery? Because unless we actually match what we found in surgery and then does it match with the culture reports and actually was it infected, till then it will not really make sense, because you can't say, okay, the PET-CT, it's a new test. It says there's infection. How can we confirm that unless we actually find operative findings matching what the leukocyte PET-CT is telling us? So these are the next few cases which will highlight that. So this was a gentleman who was referred to us with a PGI. Before coming to us, he developed a PGI, was in sepsis. The other hospital where he was on inotropic supports. They'd done an aspiration which did not show any cultures, but it was obviously infected. They gave him empirical antibiotics. He clinically improved. He still had an acute kidney injury, but it was improving. By the time he came to us, it was 10 weeks. The periprosthetic infection clinically was still there. So he was at 10 weeks. Symptoms were still there on empirical antibiotics. So the question for us was, there was no role of just continuing antibiotics. He needed debridement. So whether we do a DARE, let's try and retain these processes, or do we do a stage revision? And in India, I think by and large, we do 2-stage revisions. Dr. Citak from Germany will tell us more about 1-stage revisions, and maybe somewhere down the line, we can try and do those. So we all know that DAREs have certain criteria that need to be met. It needs to be early, good cover, stable processes with oral antibiofilm antibiotics available. If those criteria cannot be met, then ideally the patient should go in for a revision. So this is the test Dr. Umang spoke about, the biofire panel. We had this by then. So we decided, okay, let's do an aspiration, send it for a JI panel. And it showed an MSSA. So we knew the bug. We knew it was sensitive to oral antibiotics. The synovial fluid clearly showed that it was still infected. What we did at this stage, and this was one of the first tests, was we did an FDG labeled PET-CT. We wanted to know whether there's an osteomyelitis, whether there's medullary infection, because if that's the case, then there is no way of salvaging these processes. So what the scan told us was there was anteromedial soft tissue collection. The posterior capsule behind the femur and the tibia was infected, but there was no obvious osteomyelitis or medullary osteomyelitis, medullary infection. So it clearly showed us that these are areas that we could access with a DARE once we remove the poly and maybe try and salvage this. Patient having multiple comorbidities, just recovering from sepsis, we decided after detailed counseling with the relative that we'll do a DARE. And there are now evidence in literature showing that up to 3 months DAREs do as well as stage revisions. And this is where again a team comes in. Dr. Vivek Shetty, who's a senior arthroplasty and trauma surgeon, he was a part of this, and we all together took this decision with the relative, and we did a DARE, and this is how the patient gradually improved. The cultures matched with the biofire JI panel, which is extremely important. especially in a new diagnostic test, we need to know where it sits. Started on cefazolin, and rifampicin for an MSSA was given at about 2 weeks. He gradually went on to improve clinically. This is at 4 months and this was 24 weeks, 6 months. He was walking independently without a stick, and we recently had his 1-year follow-up. He's absolutely asymptomatic. We stopped antibiotics at around 4 months when his CRP and everything, I mean, he clinically absolutely stabilized. The knee was not warm at all. And this was one of the cases where leukocyte PET CT helped us decide whether we can salvage a process or not. Not saying that doing a DARE is always successful with their own challenges, but at least we had some objective evidence. Similarly, this was a fracture-related infection with a long tibia fixation. We had pain at the fracture site. MRIs, we know in this kind of a setup will give us a lot of artifacts. We did a leukocyte PET CT or a WBC PET CT, which showed us abnormal uptake or increased uptake at the non-union site, but the remaining plates and screws did not show anything obvious. But once it's a non-infected non-union with infection, we know the entire plate has to be removed. All the screws have to be removed. All the screw holes have to be scraped out. So the fracture site was classically infected. But the proximal screws also obviously showed biofilm and obviously showed granulation tissue, which was not picked up on the PET CT. So this, and both sites which sent separate cultures, both grew a Staphylococcus capitis. And this is one limitation maybe, that very, very low grade infection may not be picked up on a leukocyte PET CT, but it did not really change our line of management because it did pick up infection at the non-union site, which is what we were looking for, and it gave us that information. So this was a PGI with stems on both sides. We had early recurrence after a revision TKR, and this was also done for a PGI. So patients had persistent infection in spite of multiple debridements and revisions. The PET CT clearly showed infection in the joint, in the synovium, posterior capsule. That's exactly what we also wanted to know, whether there was infection along the medullary canal, along the stems. And there was really not much uptake in the proximal and the distal aspect of the stems. Now, the options obviously in these cases are revising this, excising a lot of bone, putting in a tumor prosthesis versus an arthrodesis versus a higher boundary amputation. Unfortunately, because of socioeconomic constraints, that option is on the table every time we discuss, and it's actually not a complication. It's one of the solutions to a problem. And if it's looked at it from that point of view, then the patients who've had multiple surgeries in spite of, multiple antibiotics, targeted therapy, they've not done well. And this is what the patient and the relatives chose. I mean, we send them for a counseling before the surgery to a processes center to decide and see what kind of a life is available now. They can live a good life with the new processes which are available. And that's what we did. We did a higher boundary amputation. Now, for theoretical purposes, what we did was we sent cultures from the proximal aspect of the femur canal just next to the stem to see whether it grew something, because that area did not light up on the PET CT. The joint and the synovium did. So the joint and the synovium obviously showed infection. The medullary canal eventually grew non-tuberculous mycobacteria, or NTM, which Agashe is also going to be touching on. It's a new challenge we're facing, all of us are facing. So again, it was such a low-grade infection that did not light up. Again, telling us that maybe if it's very, very minimal infection, it may not, the leukocytes may not really accumulate there. Whereas in the joint and the capsule and the synovium, it was florid infection. So, unfortunately, these are the cases that we're seeing now. A lot of PGIs coming up. This is another patient with high BMI with a PGI of the right knee. The bone processes interface, the joint, everything lit up very high. Clearly a case of PGI. The medullary canal showed physiological uptake. Now, the nuclear medicine specialists, they decide that based on the uniformity of the signal, whether there are isolated abnormal spots and does it match with the opposite side. So it's a full body test. It's not a localized test. They match it with the medullary canal on the opposite side and decide whether there's infection or not. What they said was this was physiological uptake. The joint was clearly infected, but the medullary canal was not. You can see here on the left-hand side, there's frank pus coming out. That's the kind of infection, unfortunately, we're facing more and more in India. And the tibia under the base plate and the femoral condyles were all infected and had to be excised significantly, excessively. And all of that matched with the PET-CT. What did not match and what we felt as surgeons, Agashe or myself, what we felt was the medullary canal looked infected. There were some flakes of tissue. The medullary canal fluid color was not normal. So we sent scrapings from the medullary canal and aspiration for tests separately, other than the remaining samples from synovium, posterior capsular tibia and femur that we had sent. And we wanted to see what we're getting on table, because if it's a medullary infection, we did ream the canal, we did scrape out the entire medullary canal, thinking that the PET-CT may not have picked it up. So the cultures from the joint and condyle show a carbapenem-resistant Klebsiella, which is exactly what Dr. Umang had shown in his series. Classically, they're treated by colistin, phosphomycin or polymyxin, but they're highly toxic drugs. And now with ceftazidime, avibactam, their things are improving. They're probably less toxic than the other ones which are available. But the medullary canal did not show anything. It was reactive medullary canal fluid. There was fibrin there. And that's where the nuclear medicine won. And as surgeons, we probably overthought that this could be infection. We did clean up the medullary canal, but at the end, it turned out to be non-infective. It was reactive synovial fluid. Now, this case was extremely challenging because she had a periprosthetic fracture, after which she developed an infection. And we did a PET-CT which showed significant periprosthetic uptake. Callus was infected. All the screws had abnormal signals. So here they clearly, now this is the interaction we have with the nuclear medicine team, that we want to know whether every screw is infected, because that changes our management. And they clearly said that every screw has an abnormal uptake. So we went in and we decided that, there is callus. Maybe we can scrape it out. If it's stable, we'll try and salvage the fixation if that's feasible. But when we went in, what we saw was absolutely necrotic avascular distal femur with bags of pus, significant osteomyelitis around the screws and in the medullary canal. And that femur was not something that could have been salvaged. We had that discussion again with the patient and the relatives that this femur has to come out. It's about 25 centimeters or so, because it's infected, it's avascular, it's dead bone. Nothing can be done about it. There is no way of salvaging this. And here, the patient relatives chose to salvage the limb. So we did a massive excision, used external fixator rods as temporary internal spacers, like an arthrodesis for the time being, using rod-to-rod clamps. And we used the cement syringe kit to make the medullary spacer. And it's an ongoing story with this patient. We'll go in for a tumor prosthesis once the 6 to 8 weeks of IV antibiotic therapy are done. Now, this interesting case was one of the few false positives that, or probably the only false positive that we picked up. He had an old fracture many years back, came in with signs of acute infection after maybe, I think, 30 years or so. PET-CT picked up abnormal signals, but when we went in, we clearly found no infection. It looked like metallosis from a very old plate which was put in and was confirmed in histopathology. All cultures were negative, no antibiotics were given, and the patient clearly settled. So this was one of the false positive cases that we found. So overall, we've assessed 16 out of the 34 PET-CTs that we've done, because we operated these 16, of which 9 were FRIs and 7 PJIs. Abnormal uptake was seen in all cases, of which only 1 was non-infective. All the others were infected, and that was that metallosis case. Low-grade infection was missed in 2 sites, the cases which I showed, but it did not really affect the surgery plan. And more, we'll see such cases now that TKRs have finished about 10 or 15 years in India, and we'll start seeing these cases with suspected aseptic loosening, like this gentleman who came in at 10 years, afebrile, but swelling going around, effusion going around for 9 months on antibiotics empirically. MRI showed aseptic loosening on the tibial side. The aspiration was not suggestive of infection. Biofire panel was negative, but the leukocyte PET-CT said that the medial femoral component is suggestive of infection. So we went in, we said, okay, we've got some evidence that it may be infected. Let's do a 2-stage revision rather than going in gung-ho and putting in a process on day 1. There was hemorrhagic fluid. It looked like a resolving hematoma. It did not look grossly infected. And we felt whether PET-CT was, again, it was like a metallosis kind of a thing, that PET-CT was again giving us a false positive. So we use these prefabricated articulated spacers, which are a new thing which have come out now. It saves a lot of time in making these molds. Biofire, again, negative. Cultures were all negative. Histopathology showed chronic synovitis with no granulomas. But an NTM PCR was done, which is, again, a new diagnostic test, which is done for NTM, which clearly showed that this was an NTM infection. That's why he had low-grade, very mild symptoms, minimal pain, and the MRI looked more like an aseptic loosening, whereas the leukocyte PET CT was positive. We're obviously waiting for the NTM culture. So as far as our early experience with this is concerned, the limitations are it's costly. It may not be available in most centers or most cities in India. It takes a little longer than an MRI, but we are certain that it has a place with implant-related infections. It does tell us whether the patient, the process of the fixation is infected or not. Maybe once we see more cases of metallosis, we'll have to figure out where it fits in as far as metallosis-related revision is concerned. But it did tell us a lot about the extent of infection and helped us in our guidance. So that's our early experience, and I'm just representing the work of all of these consultants and specialists across various departments. So it's a team, and even the biofire study Dr. Umang was talking about belongs to all of these people from this team, and it's not just my study. Thank you.
Thank you, Dr. Aditya, for an extensive talk on the new PET CT leukocyte based. Next, I'll go to Dr. Professor Agashe. He'll talk on non-tuberculous mycobacterial orthopedic infections, the new bugbear. Over to you, sir.
Good evening, friends. And at the outset, I sincerely thank the organizers of this wonderful meeting. So my talk is on a new bugbear. Now, friends, these are legendary creatures, and we used to use them to frighten disobedient children. But one must remember that these non-tubercular mycobacteria are real demons. They are far worse than bugbears, and we, as medical community and orthopedic surgeons, should be really concerned about them. Now, the next question will be, why in India? I mean, we are in TB endemic zone, and the moment I see an TB, I pick it up. We are actually experts in managing mycobacterial diseases. Friends, these non-tubercular mycobacteria are, yes, they are acid-fast, but they behave differently. They don't behave like Mycobacterium tuberculosis. They do not respond to anti-TB drugs. And remember, both MTB and non-tubercular mycobacteria pose a grave threat to public health. Now, what is the difference between MTB and Mycobacterium tuberculosis? These NTMs are ubiquitous. They are in water, they are in soil, and they are everywhere. And very important is direct inoculation is an important mechanism of NTM infection as compared to or as opposed to Mycobacterium tuberculosis. And therefore, it can cause post-joint infection, post-arthroscopy infections, or post-osteosynthesis infection. In addition, of course, it can cause or it can be a part of disseminated disease, can cause osteomyelitis, septic arthritis, synovitis, soft tissue infections, spondylodiscitis. All that is common in MTB also. But the surgical aspects or post-surgery infections are more likely to be NTMs. Another important thing is the diagnosis is generally challenging. They are acid-fast. The gene expert is negative, so that actually indicates that this is NTM and not tuberculosis. Histopathology is almost similar. Now, they are commonly found in, or they can grow in aerobic media also if the incubation period is extended. Mycobacterial media, the commonly used are Elze and Midger. They also pick up NTB. And of course, some additional tests need to be done to differentiate Mycobacterium tuberculosis and NTM. Now, recently, NTM PCR, as Dr. Menon mentioned, is introduced, as well as NTM media. But remember, they are of different types. They could be slow growers or they could be rapid growers. Rapid growers are the one who grow in less than 7 days, or they, by definition, they grow in less than 7 days, but generally they are found to grow by about 12th day. So still, even though they are called rapid growers, they are actually slow growers as compared to our routine aerobic, routine bacteria. Now, all this makes diagnosis very challenging, and therefore, most of the series report delayed diagnosis, and the mean interval between presentation of symptoms and diagnosis in most of the series is more than 12 months. Now, what is the challenge involved? One, they're often treated as culture negative cases because nobody keeps the culture for a long time beyond, say, 3 or 4 days. They're erroneously treated as Mycobacterium tuberculosis infection with conventional treatment with poor result. To give an example, this was a young boy who had arthroscopy about a year ago when he presented to us with fever, severe pain and swelling in the right thigh. So 6 months after his arthroscopy or arthroscopic ACL, he developed infection. The surgeon did incision and drainage. The cultures were negative. Histopathology was not done. So empirically, he was put on IV piperacin and tazobactam. Unfortunately, the symptoms persisted and he approached us. This is the MRI presentation. You can see there's a large thigh abscess. The femoral tunnel osteomyelitis is also there, while there was hardly any infection on the tibial side. So when we explored, we found significant pus on the femoral side. We did a thorough debridement, removed all the implants. And this is the protocol that we have developed of going all out for diagnosis or achieving microbiological diagnosis. And we note down the sample, the containers and test and do all these tests. Now, his AB smear was positive, his gene expert was negative. So it was a definite indication of non-tubercular mycobacteria because gene expert is specific for Mycobacterium tuberculosis. His 4 days culture was negative, but based on these and histopathology, the ID specialist decided to start amikacin, linezolid, and clarithromycin for non-tubercular mycobacteria. Unfortunately, he continued to have problems. Why? Because he grew Mycobacterium fortuitum, which was resistant to clarithromycin that was being given. And once the medicines were adjusted to amikacin, trimethoprim, sulfamethoxazole, and doxycycline, his symptoms settled within just 2 weeks. This is him at 4 years. You can see full range of movement, no pain, and no evidence of infection. Remember, friends, post-arthroscopic infections, especially with use of glutaraldehyde, are common. There have been several outbreaks of infection, NTM infections after endoscopy, and therefore one should not use glutaraldehyde for sterilization of endoscopes. Coming to another case, this was a middle-aged man who had excruciating pain in the right hip for 3 months. He came to us with high fever, high WBC count, and raised ESR. X-ray and MRI both showed destruction of femoral head, acetabulum, soft tissue involvement, and total loss of joint space. Obviously, we are dealing with an infective arthritis. Tracing history, he had dull pain for a year. MRI was inconclusive. So the surgeon decided to get an MR arthrogram done. Post-arthrogram, in a month's time, he started getting very severe hip pain, developed fever. He was put on empirical antibiotics, but which did not help. 1 month post-arthrogram, a CT-guided aspiration was performed. Smear was positive for AFB, and histopathology showed granulomatous infection. That was good enough for the orthopedic surgeon to initiate conventional 4-drug ATT. The cultures were negative at 6 weeks also, but obviously cultures are often negative in Mycobacterium tuberculosis cases, and therefore 4-drug anti-TB drugs were continued. His pain increased significantly, and when he presented to us, we said, "Arey, this is a post-procedural mycobacterial infection, which is not responding to ATT. So we are in spot suspicion. I cannot call it spot diagnosis, but a spot suspicion of NTM infection." Since the hip was already destroyed, we explored. We realized that the head was destroyed. The acetabulum was significantly involved. So we did an excision head and neck. Femur, here you can see the destroyed head. And the histopathology was chronic granulomatous. But on 12th day, he grew rapidly growing non-tuberculous mycobacteria or Mycobacterium chelonae. He was initially treated by a pulmonologist with amikacin 3 days a week, clarithromycin, and linezolid. Unfortunately, the problem continued. The sinus just persisted. So then the protocol was modified. Instead of 3 times a week, it was changed to 5 times a week, and clofazimine was added. The ID specialist also insisted on repeat thorough debridement and antibiotic insertion. Now here you can see within just 2 weeks, the wound improved. We inserted tobramycin cement, and this is at 2 years, no medication, no signs, but had an unstable gait. So my friend did an arthroplasty, and this is at 3 years follow-up. Now, what will I do differently in these cases? Today, I'll put a spacer instead of beads and would probably do an early arthroplasty. Friends, one has to remember, MTB may be a medical disease, but NTM is a surgical and medical disease. Aggressive, meticulous debridement is needed in cases of NTM. How common is it? About 1.5% of all microbial cases in Denmark were non-tubercular mycobacteria. And of the almost 1,500 cases of non-tubercular mycobacteria, 2.6% had musculoskeletal NTM in Thailand. As opposed to that, friend, in India, the incidence may not be that low. This is a major publication from a reputed laboratory in South, where of almost 1,200 cases of extrapulmonary specimens checked, 189 patients were culture positive for TB, but 72 cases were positive for NTM. So that's a pretty high incidence. Still, it's not all that common. Most large series have 20, 30 patients because very often they are missed. But now we are likely to be faced with increasing resistance of mycobacterial and fungal disease. Now, there have been several outbreaks of NTM, and that is something we must remember. They are of great epidemiological importance. Contaminated water can be responsible for NTM infections. This was a large series of 100 patients who developed post-operative NTM infections after a new wing was added in a United States hospital. Another outbreak mainly in developed countries following cardiac bypass because of heater-cooler units being contaminated at the laboratory. Now, friends, such infections are also noted after pedicure or tattooing. So any odd thing after this very vague kind of infection, you must think of NTM. One should also remember that there is a mycobacterium called Mycobacterium marinum, which may affect people who handle fish tanks. And tenosynovitis and osteomyelitis is known. Occasionally, surgical team members can shed NTM. And this was an importance of vendor person. You know, vendor person always washes up. And this was a series of 9 cases. And in most of the cases, one single person had assisted in various hospitals. Therefore, he was sent on leave, he was trained, and after that, there was no case of NTM, even though he assisted for 28 months. A similar thing is noted when a surgeon was shedding NTM microbes while doing breast implants. Now, is it common in immunocompromised patients? Yes, in developed world, but not in Asian population. These are 3 important papers where NTM infections was more common in non-immunocompromised patients. While in immunocompromised patients, it is generally a disseminated disease and has a very poor prognosis. As regards medication is concerned, there are several different drugs that are advocated for rapid growers and slow growers. And adverse reactions are common in all these cases. The duration keeps varying. For soft tissues, they have 4 months. For bone and joint infection, rapid growers, you need to treat for 6 months, and slow growers for 14 to 20 months. It's a big challenge to tailor antimicrobial medications for NTM. Friends, generally the outcomes are poor. Here, almost 30% cases discontinued antimicrobial drugs. Another series, only 46% had full recovery. But the most glaring or most depressing presentation is here. Of the 24 non-spinal cases treated in Colorado, 4 out of 14 had to undergo amputation because the infections could not be controlled. And in all cases, prostheses had to be taken out. While in China, people have been using traditional Chinese medicine, and then they claim that most of the patients get good results. So finally, friends, not all AFBs are Mycobacterium tuberculosis. One must remember there's something called non-tubercular mycobacteria, which are increasing in incidence. There's generally a delay in diagnosis and treatment. They do not respond to anti-TB drugs. Resistance to drugs is common. Tailoring drug regime is very challenging. Adverse reactions are very common. And unfortunately, complete recovery is not common. I'll end my talk with this slide where my friend, ID specialist, says that in these cases, I believe more into aggressive debridement by orthopedic surgeons. And I humbly mention that I do not, and as an orthopedic surgeon, you should not start medication for non-tubercular mycobacteria. Leave it to intelligent people like ID people. Thank you, friends.
Thank you, sir. Thank you for an elaborate talk on the non-mycobacterial tuberculosis. And this is the end of our first session. And over to Aditya Menon for any key questions or any discussions of the end of the first session.
Yeah, thank you, Dr. Vishnu. A couple of questions to Agashe sir and Dr. Umang. Agashe sir, if you could recapitulate what clues can orthopedic surgeons, because not everyone would have an ID physician accessible. So are there any clues when a patient presents that it could possibly be an NTM? Because we are seeing quite a bit now.
Right. So first and foremost is NTMs are common after procedure or a direct injury. They are common after open fractures and common after procedures. So any infection which is little bit lingering, which is culture negative, which is not responding to antibiotics, then you should think of, your antenna should go up and think of NTM.
Okay.
Especially if the smear is positive. Dr. Umang, you would like to say something?
I think so. You have summarized it quite well. And by and large, as you said, more instrument-related procedures, as Sir said, especially arthroscopies or any other scope-based procedures, wherein the patient has come in with symptoms maybe 6 months, 8 months, a year and a half down the line, slow lingering, as Sir said. So that is where your antennas go up. I completely agree, sir.
And I think histopathology plays an equally important part in in these cases, other than the NTM cultures and the PCR.
Yes.
Dr. Umang, to you, there are a lot of new tests which are coming up. It's very difficult for orthopedic surgeons to, one, understand them, have all the knowledge about which new gene expert or pyrosequencing what do we ask for? We're still stuck to our gram smear and bactec cultures and all of that. So at what stage, as an ID physician or a physician interested in bone infections, would you want to be involved by an orthopedic surgeon? Would it be at the end of maybe a no growth or end of a culture report? And what stage would you like to be involved?
Thank you, Aditya, for that very kind question. I think the ideal time for us to be involved would be pre-operative, frankly. So a lot of clues actually can be gained from the history of the patient. So even if we pertain to TB itself, has the patient previously, whether the patient previously have TB, has the patient been exposed to anti-TB drugs? Does the patient have any evidence of exposure for an MDR from an MDR patient, etc.? These are the things that once these things are extracted, that is how we will uh, tailor our diagnostics as well as therapeutics. We will also help if we are involved early. We can also help you understand what all samples need to be sent, how they need to be sent. So if you find any pus sample, we would prefer that that be sent in a Bactec bottle rather than just as a separate on entity and all that. I think it's a discussion between a physician and surgeon which will eventually lead to optimized outcomes. And even as a physician, whenever I'm deciding my treatment, a lot will really depend upon what your input is when you actually go inside and see the joint. Does it appear infective? Does it not appear infective, etc.? So if we are involved from the starting of the case, I think as a team, we can optimize patient management much better.
Great. Thanks. Thanks, Dr. Umang. Vishnu, I don't know if Dr. Banerjee is online.
I think he has left. He has some work.
Okay.
So thank you for an excellent the part one of this webinar. So next we'll move to the part two where it involves the specialty part, and over to Dr. Chinmay Nath on his talk on spondylodiscitis assessment, diagnosis, and treatment.
Yeah, good evening, Vishnu, and good evening, all the esteemed speakers and the viewers. Am I audible? Clearly?
Yes, sir.
Yeah, thank you. So my topic is something different, but it is allied to the musculoskeletal infection. It is specialized spondylodiscitis, that means infection of the spine. Spine comprises a bone, but it has another part, that is neural tissue. So you cannot do a radical debridement without thinking of the condition of the neural presence of the neural tissue. So what is spondylodiscitis? It's an inflammation and infection of the vertebral bodies and the disc space. It may have multifactorial etiology. It may be a complex disease. So multidisciplinary approach is absolutely needed. About 0.4 to 3.4 per lakh per year is the incidence rate, and it's rising. The main manifestation of the hematological spread spondylolitis osteomyelitis is more than 50. Male-female ratio is 1.5 to 2 is still 1, and it may have a bimodal distribution. It is seen in the first and second decades, as well as in the fifth and sixth decades of life. Etiology may be phyogenic, may be granulomatous, including tuberculosis, which is very common in our country, but it's a different ball game and it's a vast subject, so I will not include much in my topic. And fungi. Currently, TB is the most common. It's increased in incidence in last few years. BT, maybe BT, beta diagnostic tests over a couple of decades, which was already discussed in the first part of the webinar by Dr. Umang and others. and resurgence of the tuberculosis, increased use of intravenous drugs, increase in immunocompromised patients, rise in bacteremia and pathogenic infections. The infections of the spine have a large spectrum of clinical manifestations. The structures involved may be vertebral bodies, intervertebral discs, spinal canal, and paravertebral fractures. Very rarely in the posterior element of the spine. The condition predominantly affects the lumbar spine, followed by thoracic and cervical spine. These are the distributions in steps. And there are 5 key elements for the surgical decision making. The Infectious Disease Society of the America identified 5 key elements for decision making in spondylodiscitis, like infective agents, segmental instability, abscess development, neurological compromise, and focus of infection. There are certain risk factors like conditions affecting the immune system, such as diabetes and chronic kidney disease, we all know. Previous spinal surgery. Outpatient spinal procedure. We do not pay attention to this, but the spinal injections, nerve blocks, intradiscal injections, discography, etc., can cause spondylodiscitis. Urinary tract infection, very common. Excessive alcohol consumption, intravenous drug abuse, or organ transplantation, intravascular implants, advanced age, rheumatological disease, cirrhosis, underlying malignancy. Pathogens may be monomicrobial mostly rather than polymicrobial ones as compared to other musculoskeletal infections. Maybe TB, maybe Staphylococcus aureus in most cases of the pyogenic spondylodiscitis. Second most common group is Enterobacteria, 7 to 33%. Streptococci, Enterococci also common, 5 to 20% of this. Anaerobes are very rare. Coagulase negative Staph aureus resurging, and Streptococcus viridans also. So the route of infection may be hematogenous and non-hematogenous. And the commonest route of infection is hematogenous. It may be, and non-hematogenous may be contiguous or direct inoculation. The origin of infection may be outside the spine, maybe genitourinary tract, thirds, kidney, soft tissue, GI tract, infected implant device, oral cavity very rarely, and respiratory tract more rarely. The potential area of inoculation at the spine is metaphyseal area of the vertebra and cartilaginous end plates. The pyogenic spondylodiscosis, starts when bacteria reaches the metaphyseal vascular arteries, and then bacteria reaches the proteolytic enzymes, then intervertebral disc is destroyed first. But on the other hand, in TV spondylodiscitis, we usually switch with veins, that's something flexor. So there is discitis. In case of children, it's the story a bit different. Discitis is very common in children because this is still vascular. Pathophysiology in children is different from adults. Persistent vascularization that may provide an idea for bacterial inoculation inside the disc that is not common in case of adults. Metaphysis in children have a high blood network, rich blood network with anastomosis. It protects the body from extensive destruction in case of infarction by septic embolus as compared to the adult spine. In adult spine, intraosseous arteries and end arteries compared to the children where there are anastomosis. So septic emboli in adults gets entrapped inside the vertebral body cells rather than this. There is extensive destruction of the bone with collapse, bleeding, and infection extends to the adjacent disc and the vertebra. That is the story. So the posterior, in the posterior fractures, it is a poor blood supply, which registers actually hematogenous pyogenic infection, but each infection occurs, it's very difficult to trace. But as the posterior fractures is easy to approach, it can be treated surgically in better ways. So the extensive vertebral destruction may cause deformity, instability, and neural compression, which is unlike in other areas of musculoskeletal infection. So the uncontrolled infection is present as paravertebral abscess, meningitis, epidural or subdural abscess, high morbidity, and mortality because of presence of neural stasis. So the direct bacterial inoculation may be sometimes iatrogenic, which we should always keep in mind during spinal procedures, diagnostic and therapeutic spinal procedures. The culprits, the iatrogenic inoculation accounts for 14 to 26% of the spinal infection. It's not very uncommon. And the contiguous spread is extremely rare, the third one. The infection may spread from the adjacent structures like aorta or esophagus. Now, coming to the clinical presentation. Clinical presentation is most of the cases very vague and non-specific. There may be back pain with stiffness, neck pain with stiffness, which works, which nice, and sometimes fever accompanies, sometimes there is no fever. There is malaise, lethargy, confusion, nausea, vomiting, anorexia, and weight loss. All these are very common non-specific complaints. There may be localized tenderness, paravertebral muscle spasm, restricted range of motion of spine, and in case of cervical spondylolisthesis, there may be dysphagia or torticollis. There may be neurological impairment. Very dangerous, maybe paralysis, maybe a bit less sensory deficits, muscle weakness, radiculopathy, but not very uncommonly sphincter dysfunction and caudal syndrome. In case of children, the neurological deficit is a bit uncommon, but may present with abdominal pain in case of lumbar spine involvement, back pain, both sensitive movements. There may be low-grade fever, there may be difficulty in walking, irritability, or inability to bend forward. In elderly, high prevalence of comorbidities, degenerative back pain may be confusing and it's very difficult to diagnose clinically. Pre-existing cognitive impairment also exists. In the past few decades, mortality and morbidity from spondylolisthesis have significantly reduced due to advances in diagnostic techniques, antimicrobial treatment, and also surgical treatment, surgery and advancing. So the diagnosis may be done by biochemical and hematological investigations, radiological investigations, and pathological investigations. Coming to the biochemical and hematological investigations already discussed by our previous speakers. These are the laboratory investigations. I am not going in details into it, but I'm going to the biopsy. Biopsy in spine is really challenging. We do not want to disturb the neural structures as well as it is the site of infection is very deep. So we take help of the CT scan or fluoroscope to approach the area with some needles like jumpsuit needles. CT guided biopsy can be done very in the CT suit or the daycare theater with fluoroscope and transradicular biopsy can be done, which I do myself and all the spine surgeons do. The culturing of the organism taken from the infected tissue is most definitive case. The pathogenic agents may not be identified in 40% patients in the link. The PCR is helpful in this and already discussed by our previous speakers. Now coming to the radiological investigation. MRI is the gold standard, but the X-ray has not become actually. There are CT scan, there are fluoroscope, there are nuclear scan. The X-ray may show, maybe the X-ray finding may be absent at the outset, but very subtle early changes may be seen. There may be loss of vertebral height, this height, loss of inch definition. It may reveal sometimes extent of bone destruction in a later stage or indicate coronal and sagittal malalignment available. But X-ray is not recommended in each and every head person. But there are certain red flags which gives us alert when urgent X-ray is done. If there is neurological symptom, if the age is less than 20 or more than 55, if there is previous history of malignancy, previous history of surgery, if there is HIV infections, or if the pain is non-mechanical in nature. Now coming to MRI, which is a gold standard, it's spondylolisthesis. It has 96% sensitivity and 92% specificity. It can be discussed, diagnosed with T1 and T2 weighted images. Post-gadolinium contrast image is very helpful. In acute spinal infections, increase in fluid signal due to marrow edema is demonstrated. Infection mostly begins near the anklet in adults. Irregular signal intensity on T1 weighted images. Edema typically affects most of the body and weapon disc and peripheral enhancement. These are the two different pictures in T1 and T2. There is low signal intensity in T1 and high signal intensity in T2. And the contrast enhancement with gadolinium in T1 weighted images. CT scan. MRI may overestimate sometimes the extent of the infected tissue. Sometimes in old age person, the inflect changes, the modic changes can cause the spondylolisthesis. So therefore, additional information from the CT is needed. CT with radiopaque contrast may be necessary when the MRI is contraindicated in some cases. CT shows inflect destruction of erosion, reduction of vertebral fat and depth, hypodensity, sequester formation, bone necrosis, pathogenic classification, paravertebral disease extension, and epidural abscess formation. Now, coming to nuclear imaging, already very vividly discussed by our esteemed colleagues, Dr. Agashe, Dr. Agarwal, and Dr. Aditya. So I'm not going into details into it. There are three phases: technetium bone scan, then with gallium 67 scan, and then with FDT. So these are the PET scan, which can show there is infection in the spine from the Elbasset, which is mainly 100% of the risk. Now coming to the management. And management can be conservative, maybe operative. Mostly conservative, but selected phases, surgery is necessary. So the goal of treatment is eradication of the infection, prevention of and restoration of the spine structures, maintenance of stability, prevention and correction of the neurological deficits, and release of pain. Last one, which should be always kept in mind. So the conservative treatment, the most people are successfully treated by this method. If we choose the appropriate antibiotics, it could be IV, and it should be guided by the tissue and sensitivity. Then it should be successful. Analgesia, immobilization with rest and braces, supportive therapy, and sometimes after the control of infection, physical therapy to restore function. Immobilization by bed rest and braces. Bracing decreases strain and stabilizes spine in some extent and prevents deformity. Initially, bed rest is recommended, but only in the first phases nowadays. Ambulation using brace is recommended after 3 weeks. Brace immobilizes the affected spine. Some recommends bed rest for 6 weeks, but many are not proponent of that. The mobilization related morbidity are there, like pressure sores, deep-vein thrombosis, pulmonary embolism, and metastatic pneumonia. Route of antibiotics should be IV, and choice of antibiotics could be according to the sensitivity, but in many cases in spine, sensitivity cannot be established. So sometimes we have to use empirical antibiotics like this. And there is controversy about the duration of antibiotic therapy. The recommended duration varies from 4 to 12 weeks. A randomized control trial published in Lancet shows that the 6 weeks therapy is not inferior to 12 weeks therapy in 349 patients. A weekly decrease in CRP level by more than 50% is adequate progress index, so we should follow this. Now, when we should discontinue antibiotic microbial threats managed after success? If there is clinical improvement, still it is valuable. Resolution of the symptoms and signs and normalization of the CRP. Now, going to switch over to operative treatment when conservative treatment fails. There is high chance of, if there is high chance of fibrosis and instability, then we should go for surgery. And if there is spinal deformity already established, or the chronic pain which is not subsided, mechanical pain, then even after the control of infection, we should go for surgery. And it should be discontinued after 4 to 6 weeks if it is not successful. It's surgical case. With modern conservative treatment, morbidity and mortality reduced from 56% to 25% over the last 15 years. But still, some patients of spondylolisthesis require surgery. But the careful selection of the patients in surgical treatment is very necessary. Some of these indications are maybe absolute indications, relative indications. The absolute indications may be spinal cord or quadriplegia compression, progressive neurological deficits. Relative indications may be spinal stability, extensive bone destruction, significant deformity, failure of conservative treatment. There are different surgical procedures, start from surgical drainage to aggressive debridement and tissue sample collection, decompression of spinal cord, quadriplegia and nerve roots, reconstruction, stabilization, and finally correction of the deformity. There are a variety of surgical procedures and techniques like different approaches like anterior, posterior, or combined approaches, as most of the infections are anterior. Previously, anterior approaches were preferred, but nowadays, with that particular technique, we can approach posteriorly, but take down the anterior infection very well. Stages may be single stage or 2-stage procedures, with or without instrumentation. Minimal invasive procedures are not. I'll show 2 index cases. So this is the first case. 60-year-old female, laminectomy and decompression done elsewhere, which at L4, L5, and L5. After that, radicular pain was relieved, but there was severe back pain, which was new and very stiff spine. Inability to stand or difficulty on standing on bed, but there was no fever. Patient was hypertensive, diabetic, ischemic heart disease, and bronchial asthma. IV antibiotics started for 4 weeks, no improvement. So they came to me and we did surgery through anterior approach. And the tissue was sent for culture. Assiut came. Then second phase, 51-year-old female. She had TB spondylolisthesis. We take forward phase with grade 3 paralysis, progressive neurodeficits. Antitubercular drug started. After 4 weeks, there was no neurological improvement. So surgery was done with posterior approach. Anterior part is taken down by posterior approach and posterior fixation was done. Neurology recovered after 4 months. So then, as final infections commonly involve the vertebral body, an anterior surgical approach with decompression and debridement usually recommended. But with recent posterior transpedicular techniques, anterior debridement can be possible through posterior approach. So my take-home message is that spondylolisthesis has signs and symptoms. There is low threshold for MRI and biopsy. There should be early intervention rather than late. Conservative treatment is successful in most of the cases, but surgery is needed in some cases. Surgery must be debridement, tissue collection, plus stabilization, with or without nasal decompression, with or without deformity correction. Thank you very much for your patient listening.
Thank you, sir, for your extensive talk on spondylodiscitis. And next, I'll invite Professor Citak from our Endo Klinik, Hamburg, who is going to give an extraordinary talk on one-stage septic exchange. Over to you, sir.
Thank you so much for the invitation. It's a great honor for me to give the talk about the one-stage septic exchange. So thanks for Aditya Menon for the invitation. He was with us in Endo Klinik 2018, and then since then we have a friendship. So I visited him in Mumbai 2018, and we have met last time in Graz at the EPGIS meeting 2022. So I'm working, as you said, in Endo Klinik Hamburg. Endo Klinik Hamburg is located in Hamburg, the second biggest city in Germany with 1.8 million people. It's not a big city if you compare to other cities in India, but we are, our arthroplasty center is the largest arthroplasty center in Europe, and we are doing like 8,000 arthroplasty cases in a year. And if you look at our septic cases, we are doing round about 500 infected arthroplasty cases in our institution. So the one-stage septic exchange has been introduced in Endo Klinik many years ago in the 1970s. And this is a nice article from my chief Gerke, and as he said, it all began here. Until now, we have done more than 10,000 cases, and in our infected cases, we are doing in 85% of our cases the one-stage septic exchange. As you know, the two-stage septic exchange is worldwide the golden standard, but still in Endo Klinik, this technique was introduced. We are doing in 85% of our cases the one-stage septic exchange. In every infected case, I think we need a multidisciplinary approach, as you can see, because those patients are really difficult to treat. They are multimorbid. They have, it's like a tumor. If you look at the tumor, they have a specific tumor board, and that's the reason we also need a similar approach for the septic cases. So we are surgeons, we need a microbiologist, we need an infectious disease specialist, and so on. We have done this many years. If you look in the literature, you can find that regarding this multidisciplinary approach, you can have better results treating an infection. So this is the algorithm of Endo Klinik in Hamburg. Of course, we cannot do in every case in a one-stage septic exchange. First requirement, of course, we need a chronic infection. And chronic infection means if you have the symptoms more than 3 weeks, you will have a major biofilm. And in those cases, you need the exchange arthroplasty. This is required for the 1 or 2 stage. But to be honest, to do the 1 stage, we have to identify the pathogen. If you look at the recent presentation from other colleagues, it's not always easy to identify the pathogen. And if we can, but we have to identify the pathogen to do the 1-stage septic exchange. If not, as you can see here, we are going also with the 2-stage septic exchange. We have still some special patients, so we are also going the 1 stage in culture negative infections. I will show you later on in which patients we are doing the the one stage, sorry, in culture negative infections. Of course, if the patient has local antibiotics, the allergy against antibiotics, it's not possible. So we have to adjust local antibiotics, and the radical debridement has to be also possible. In those cases, if we fulfill those criteria, we can go for the one-stage septic exchange. So, of course, if you talk about the indication, you have to talk about what happened to the patients. They have a one-stage septic exchange and they failed after one-stage septic exchange. If you do a repeat one-stage, you can see that the results are worse than the primary one-stage septic exchange. If you look here in total knee arthroplasty, 52% had an infection-related failure, and the infection-free survival rate was 59%. It's quite low, but you have better results in hips. But to be honest, you have similar results also with a two-stage septic exchange. If you do another septic exchange after a failed treatment for a septic exchange, for a septic failure, you will have a high failure rate in those patients. So I was mentioning this already. We have in selected patients, if we cannot identify the germ, we are also doing the one-stage septic exchange. And the treatment is quite a little bit different, because usually we are giving IV antibiotics for 10 to 14 days in a normal situation, in a normal setting, I would say. But if we have culture negative infection, we are doing similar to the normal one-stage septic exchange, 10 to 14 days. But then we are switching to oral antibiotic treatment for the next 4 weeks. And the survival rate is quite good with 86.4%, a little bit lower than the normal patients where we can identify the germ. But this type of treatment we are only doing in patients they have ASA score more than 3, so there are multiple comorbidities, and maybe they are not able to tolerate multiple surgeries. For example, if you do the two-stage septic exchange, they will never get reimplanted because of mortality rate in the interim period during the two-stage is quite high. So in those patients, we are also doing the one-stage septic exchange, even in patients if we cannot identify the germ. So this is another extended indication, because if you look at the ICM criteria, a fistula is a relative contraindication in our institution. If we can achieve a primary wound closure, it's not a contraindication if the patient has a fistula. We have also published this recently in the HSS journal, and you can see that the success rate is around about 80% in a follow-up of almost 5 years in this cohort of patients with fistula and total knee arthroplasty. So if we talk about the one-stage septic exchange, I can recommend you this book. This is just published with Springer. So I'm one of the editors of this book. So one-stage septic exchange, you can find every information regarding the one-stage septic revision arthroplasty. And I like this slide. I developed this slide. This is a slide with a 10-step approach, because if you look here, we have I have separated in preoperative, intraoperative, and postoperative. Of course, preoperative, I was mentioning already. So the correct diagnosis is important. So we have to find the germ. We have to find the suitable patients. So of course, this is also in every surgery is important. The suitable patients, and of course to optimize the patient. Those are preoperatively very important. And as I mentioned before, the multidisciplinary approach, analog to the tumor board in the tumor patients, we have to discuss the patient in advance, and we have to find the perfect antibiotic therapy, because the microbiologists, infectious disease specialists, they are more familiar with antibiotic treatment than we are, because we are surgeons. So we have to work closely with them to have the perfect antibiotic treatment. So intraoperatively, I will also show you a short video. So radical debridement, this is a key to have success of one stage. And I think it's also a key of success for the two-stage septic exchange. We have to take intraoperative biopsies, 5 to 7 samples. We need a jet lavage treatment with an antisepticum. We have to do a new setup. I will show you on the short video. And the antibiotic-loaded bone cement recommended by our microbiologist. And postoperatively, number 10. So we need the proper antibiotic treatment. So the key of success, find the bugs. We heard already from previous speakers, is not every time possible. That's also one of the reasons why we are not doing in 100% of the cases the one-stage septic exchange. Right now it's 85%. So we have to know the germs, they are responsible for the PGI, and of course the suspectability of the germ. Those are the key issues to have successful results. So if you talk about radical debridement, this is the main predictor for success. You can see here, if the bone is infected, Aditya was also mentioning, if you have a dead bone in infected cases, you have to resect it. So in those cases, we are also doing the resection of the bone. We have to remove all infected tissue, and all infected tissue means also the bone. We have to remove all the foreign materials, seclage, prosthesis, everything. And the challenge here, I think, is finding the interface to the healthy tissue. This has a slow learning curve. This is also a challenge, I think, in the tumor surgery. I will show you later on maybe how can we have better results in the future, but I think we have to still work. So Aditya was showing already the resection of the bone. In this case, if the bone is infected, you have a dead bone, as Aditya mentioned. In those cases, as you can see here, we are also doing the proximal femur resection. Maybe this is more than proximal. And then we are going with a modular cemented stem. This is a stem from the Link factory, from Link company. And this is the dual mobility cup, because this is important. If you do a proximal femur resection in those patients, you can have a higher result, a higher rate of dislocation. So to decrease the risk, it's recommended to do the dual mobility cup in those cases. So this is a short video how we do the one-stage septic exchange. In majority of cases, we do not have any loose implant. And this is important to remove the implant properly to reduce the risk of any other issues such as fracture. So you have to disrupt the ingrowth between the bone and the prosthesis. You can attach the specific extractor with 2 screws, and then you can remove the well-fixed stems also in those with this device. So you can see here, this we have taken the biopsies from the entrance and from the distal part of the stem. Afterwards, you have to clean the femoral canal with, as you could see, with different type of burrs. And afterwards, you have to remove, of course, the cup. And same rule also for the cup. You have to remove the cup without having additional bone loss. This is a specific explant system. This is a very good instrument to remove also well-fixed cups with less bone loss during the removal. And once you remove, you have to take also biopsies from the acetabulum, and then you are preparing the new implant. As I mentioned before, we have to take all infected tissue, and all infected tissue means also like seclage, all infected materials, and also the bone, as you can see here now. So you have to clean the bone here. In this case, we didn't do any proximal femur resection because the bone was not had no osteomyelitis. As you could see, this was very fast, but we need a new setup. You have to change the whole setup, and you have to redrape everything. And once you finish it, you are putting the cement, as you can see here, with antibiotic-loaded bone cement recommended by the microbiologist. And then you are doing the reimplantation in the same surgery. This is a one-stage septic exchange, as you can see here in this short video. So I was mentioning already about the length of antibiotic treatment. It's 14 days systemic antibiotic treatment. We have looked for the data in the literature. This is systematic review. I was part on it. So we have compared two groups. One group antibiotic less than 4 weeks, as you can see, and the other group like antibiotic length 5.5 weeks. The range was 4 to 6 weeks. And there was no difference in the eradication rate. But to be honest, there's less data on it. I think we need more data. And I think in some cases, we have to also do more than 14 days of systemic antibiotic treatment. But this, if someone is asking me this question, I cannot answer this question until now. We are working on it, as you can see here. This is the risk factor. This has been published in the JBJS American 2019. This has also received the CCGR award. And we have looked for the risk factors for failure after one stage. And one of the failures is like almost 30-fold. I was showing already. If you have a failed one stage or history of one stage septic exchange. And this is also important if you have this type of germs, like Streptococcus or Enterococcus, you have a higher risk, and Enterococcus like 17-fold higher risk for reinfection in those cases if you treat these patients with a one-stage septic exchange. So if you look at the hip cases, this has been also published in the same year, but in a different journal. It's in Core, and one of the indications for re-revision was dislocation followed by a reinfection. And as a risk factor, it was quite similar to the study what I have shown in the last slide. And in those cases, I was showing you already in the case with the proximal femur resection to decrease the risk of dislocation. So we recommend to use dual mobility cups whenever you perform the one-stage septic exchange. So, of course, the golden standard worldwide is the two-stage septic exchange, but why we are doing the one-stage exchange? If you look here, this is also, we have published this study. This was published by a young colleague of us. According to the literature, they are the top 10 benefits, and you can see here the shorter lengths of stay. We have a lower blood loss. But these are more important, in my opinion, lower complication rate, lower mortality rate, because you are doing only one surgery compared to two surgeries. And we have better patient-reported outcome measures. As I said, there's only one surgery, so there's no interim period. We have a shorter antibiotic course, so we have less antibiotic resistancy. And if you ask the patients, it's also published in the BMJ, the patient's preference is also the one stage. And maybe the most important benefit is if you have similar eradication rate, but with only one surgery compared to the two-stage septic exchange. This is also interesting. I have done this study during my MBA thesis, and you can see this. You can see the qualis in one stage and two stage. This is a one stage. This is a two stage. So if you look at this data, you have less qualis and more cost. So in the one-stage septic exchange is better in costs and also achieving the qualis. So this is an accepted paper in Journal of Ortho. This is not published yet, but this you can see the difference of the germ between 2001 and 2022 at Endo Klinik, and you can see. If you look here, the Cutibacterium, for example, it's getting higher and higher. We are working on it to identify why we have more Cutibacterium. And I think one of our hypotheses is we have more patients, not in our institution, but in Germany. They are more doing direct anterior approach. And we know that the area of the incision where the direct anterior approach is, we have more Cutibacterium, so like the axillaris region for the shoulder. So this is maybe one of the reasons we have a higher rate of Cutibacterium acnes cases. But I think this is more important. If you look here, this is really how can I say, it's really, we will have a devastating situation in the near future, because if you look here, this is the rate of polymicrobial infection over time. And if you look here, 2001, so it went up in 2011, it went down again. But in the recent years, we have almost 40% of infected cases, they have a polymicrobial infection. And this is, in the near future, this can be really a devastating situation, how to treat those infected cases, especially the polymicrobial infections. So I was mentioning before, we have the radical debridement. This is one of the key of success. If you look here, there is a medication, it calls 5-aminolevulinic acid. So this is used in tumor surgery. You will give the patient the medication and prior the surgery. And intraoperatively, as you can see here, this is a tumor tissue. You can divide between healthy and tumor tissue. And right now, what we are working, we want to transfer this idea to the septic cases, because if we can identify with a fluorescence light intraoperatively between healthy tissue and infected tissue, this would be really game-changing. But it's not easy to have the results, but we are working on it. And you can also use it in aseptic cases, because as I said before, diagnostic is sometimes very difficult. And you can also see, because sometimes you are doing an aseptic revision arthroplasty, and then you will have the results later that the case was infected. You could also use this for aseptic cases. And the second thing is from the plastic surgery department. This is a fluorescence light. It's called the moleculite. You can use it hopefully intraoperatively to see the infected tissue. And those two ideas or projects are in process. And hopefully I can show you the results very soon. And hopefully, especially this one, will have successful results. Then this is the next and game-changing step in the treatment of infections. So my take-home message is we are talking always about the 1 and 2 state septic exchange, but I think the most important part is those patients are really, really difficult to treat, and those patients should be operated in a specialized center, because sometimes we are receiving patients, they have received 50, 60 surgeries, and then they are transferred to a specialized center. And those patients are really difficult to treat, to eradicate. So if you are not familiar with infected cases, it's not a shame, just send it to the specialized center instead of doing it after 50 cases. So I would like to thank again Aditya for the invitation, and Dhanyavad.
Thank you, sir. Thank you for your extensive work on PJI stage 1. And it was very great this. Finally, so we were all talking about the adult infections. Finally, moving to the end of our talk, our last speaker, Dr. Haesham from Assiut University, Cairo. He'll talk on pediatric bone and joint infections, how it differs from adults, and what are the key take-home points. Over to you, Dr. Haesham.
Thanks a lot to my dear colleague for this kind invitation. I really enjoyed joining you all, and I hope I can add more information for the previous lectures. Is the presentation visible to you?
Yeah.
Okay, my
it's
talk
visible,
today is
yeah.
about pediatric bone and joint infection and how it differs from adult infections. The children below the age of 1 year, the blood vessel cross physis. So if you have infection in the metaphyseal region, it could reach intra-articular region. Later on, after 1 year, the physis act as a barrier to prevent spread of infection from the metaphysis to the joint. But the acutely bent blood vessel makes the blood stream in this area is stagnant. So when hematoma occurs, it can be easily infected with any organism. While in the end of skeletal maturity, the blood vessel is continuous from the shaft to the end of the bone. Septic arthritis can also develop when the purulence breaks through the intra-articular metaphysis to the joint like hip, shoulder, elbow, and ankle, but not the knee because the metaphysis is extra-articular. and the capsule prevents spread of infection to the knee joint. Usually, it's a hematogenous spread and contaminated by staph aureus. Direct inhalation could occur due to penetrating injuries, open fracture, or surgical contamination. Immunocompromised patients are more susceptible to develop osteomyelitis or septic arthritis. In acute osteomyelitis, when infection usually occurs after hematoma formation in the metaphyseal region, the pus finds its way through sinus to form supraosteal abscess, and the sequestrated bone is detached from the original bone. And while the acute osteomyelitis developed into chronic osteomyelitis, new bone formation and involucrum acts as envelope are surrounding the sequestrated bone. Sometimes, when the subacute stage, Rhodes abscess is formed where constitutional symptoms subside and occasional pain exists. Clinical picture in acute osteomyelitis or septic arthritis, we have pain, limping, constitutional symptoms, fever, and toxemia. And locally, we have hotness, redness, edema, and restricted range of motion. We should keep attention to neonates in the ward preterm or admitted in the neonatal ICU because this clinical picture may be vague and should be suspicious. And also, conjoints were covered by thick muscle like hip and shoulder. The hotness and edema and this couldn't be sometimes very obvious. As regards the radiology, X-ray can be normal in early infection, and later on, with the progression of osteomyelitis, we can find new bone formation, osteolysis, or metaphyseal infection later on. MRI has the advantage of early diagnosis in acute osteomyelitis with high sensitivity and specificity, especially with gadolinium contrast. Ultrasound plays an important role in the diagnosis of septic hip, and aspiration guided ultrasound is very beneficial in this part. Laboratory cytosis and raised lab marker like ACR, CRB, and cultural sensitivity for specific organisms. We should keep in mind the differential diagnosis of non-infectious arthritis like transient synovitis and inflammatory rheumatoid or juvenile idiopathic arthritis. We should be kept in mind because sometimes they mimic the picture of acute osteomyelitis. Treatment includes antibiotic therapy according to cultural sensitivity, aggressive surgical debridement, and management of complications like septic arthritis and dislocation, gross disturbance and limb length discrepancy, and pathological fractures. This case of left hip septic arthritis, after the drainage of septic hip, we found that the hip is subluxed, and later on we find that it's ABN occurred, which gives a picture of Persis-like condition with fragmentation of the femoral disc. In this case, we have a broadest abscess at the inferior medial part of the neck of the femur, which necessitates curettage through load-lift approach. This is a case of destroyed lateral condyle of the femur and progressive valgus deformity. And after the infection is treated well, and we have this sequelae, this patient had been treated by pre-vascularized fibular transfer of the proximal fibula from the other side. And after union of the transferred pieces, we deal with the residual valgus deformity by osteotomy and putting a plate on the medial side to prevent recurrence of the deformity. This is a case that may simulate infection. We have pseudoarthrosis in the femur and pseudoarthrosis in the tibia on the other side, but we find clinically that the patient has congenital insensitivity to pain and multiple ulceration that makes the bone mimic charcot joints. In this case, we have osteomyelitis in the distal femur, which resembles Salter-Harris fracture, and by serial debridement, the bone is rarefied and as sequestrated bone. So in such complication, we need to remove the sequestrated bone and deal with the bone gap and limb length discrepancy. An important thing before removing the sequestrum, if we have and follow-up X-rays a progressive involucrum formation, if there is no collection of pus, you shouldn't remove the involucrum until a good contact of the involucrum proximal and distal, otherwise you will end by a bone gap. as here we have a good involucrum. So during the brightening, you should only remove the central sequestrated shaft, removing the whole involucrum and end up like this. But might need vascularized fibula, for example, to compensate it. Like in this case, after drainage of the acute pus and the formation of chronic osteomyelitis, and we have a sequestrated wound well covered by involucrum, just removing the sequestrated bone, it will end the sinus discharge and keep the length of the bone. In this case, we had osteomyelitis with histological fracture, was good bone formation and good range. The patient had gained good hip and knee function. And in cases where involucrum is not well formed and we have a sequestrated bone on repeated debridement, we can remove the sequestrated bone and put a cement spacer like musculoskeletal technique. This promotes the removal of the infected tissues and fighting the organism and act as a bridge for formation of new bone. And after cement removal, you can find new bone formation without bone loss, like this case. Surprisingly, sometimes you find that growth is overstimulated with infection, like in such case, which could be treated by drilling the distal femoral physis and proximal tibial physis to compensate for limb length discrepancy, rather than lengthening the sound side. One of the common complications of post-septic hip that we have post-septic hip dislocation after drainage of septic hip, which necessitate open reduction and pelvic osteotomy, but unfortunately, some cases have a high recurrence rate. The hip dislocation could be combined also by destruction of the femoral head or complete absence of femoral head and neck, which is difficult to be treated, or accompanied by proximal femoral fracture due to poor bone quality. And sometimes we have arthritis in the hip joint. After eradication of infection, we have to fuse the joint. This could be done by a controlled plate if there is no residual infection, or if we are suspicious, we can do transfixing wires. And the patient can gain function and walking after hip fusion after eradication of the infection. So my take-home message, you should keep in mind and be suspicious for neonate and neonatal ICU. Be suspicious for deep joint in shoulder and hip. Sequestrectomy in chronic osteomyelitis, don't do it until we have a good envelope of involucrum. And management of complications in pediatric like growth disturbance, EVN, limb discrepancy, and arthritic joint sometimes may need fusion. Thanks a lot.
Thank you, Dr. Haesham, for an extensive outline of the pediatric bone and joint infections. And I thank all the faculty for giving their expertise. And over to Dr. Aditya Menon for any key points on discussions.
Thank you, Vishnu. Thank you. Just one question to all the three speakers from the specialties. Dr. Nath, one question to you. Spine infections tend to be a little more forgiving than peripheral bone osteomyelitis. So are there any specific indications where you've done spinal fixations and you're forced to remove the implantation? Because I think from what we've heard or learned from our spine colleagues is they can try and salvage the pedicle screw fixations in a lot of cases. Any criteria for removal versus salvage in spine?
The advantage in the spine is that we most of the time we do titanium implants. Titanium implants, which there is a study that titanium implant less can cause less biofilm than stainless steel implant and plastic. So there is less chance of implant humility in implant compared to the areas of the collector. Second thing is that the highly vascular area. So antibiotic easy. So many cases can be salvaged without removing the But at the same time, you have to keep in mind getting very narrow margin of error. There is very high chance of neural compression.
Yeah. Thank you, Dr. Dr. Mustafa, are you online?
Yes, I'm here.
So, it was a fantastic talk on one-stage revision, something that I've seen firsthand. But the challenge that we face, I mean, one thing that you kept mentioning that it should be a susceptible. You need to know the pathogen, and it should be sensitive to the antibiotics. What we are facing back in India and across in the Asia Pacific is highly resistant infections, especially gram-negative. Are you dealing with something on those lines in Germany now? And if yes, would you still stick to one stage in, say, a carbapenem-resistant gram-negative, like a Klebsiella?
Yeah, thank you so much. Thank you so much for this question. Of course, you have different germs in India. Unfortunately, or fortunately, we have maybe better germs than in India. So I think, but to be honest, we have to discuss those cases with microbiologists, because one of the keys is the radical debridement. Of course, we need the antibiotic treatment, and it's also important. We have recently published a paper. We were also surprised about the preoperative germs and the intraoperative biopsy germs. There is a concordance rate only 50-55% concordance rate. This is also one of the issues, but thank God we have better germs, I think, than in India. And this is maybe one of the reasons why you are doing more two-stage septic exchange. We have no experience with this type of germs, what you have. And, you know, I'm not sure if someone is doing a one-stage septic exchange in India.
There are surgeons doing it, but it's for the limitations that you've said. But if it's these highly resistant bugs, then the results are very, very...
I know. I think, but you have also very bad results with the two-stage septic exchange, I think, right? Yeah. That's one of the issues. I think if you have those germs, it's really difficult to treat, even if you do like one or two stage. I think those cases are really, really difficult to treat. I think this is a key message what we have to say. And we have to have less resistancy, you know, to decrease the resistancy, to have better results in patients. I know we have, my background is from Turkey. They have similar different type of germs, because in Turkey, I don't know how it's in India, but in Turkey, you can just go to the pharmacy and buy antibiotics, you know. And in Germany, it's not possible. You need a prescription, and this is one of the reasons maybe we do not have any like a broad range of resistancy patients.
Absolutely. Thank you. And over to Agashe, sir, for a question to Dr. Haesham.
Yeah, Dr. Haesham, are you there? Hi, Dr. Haesham, are you there? Has he logged out? Hello?
Hello? Yes.
Yeah. Just a small question. How often you get a metaphyseal abscess bursting through the physeal plate into physis? And what are the outcomes of that? Because I'm always confused as to what is going to happen.
Well, if we have extension of infection from the metaphyseal region to the joint, usually we have a bad prognosis, because it will affect the articular cartilage and stiffness. Usually, if not well drained urgently, you may end up with arthritis, and we may have to fuse the joint. We have seen a lot of cases like this in our unit, and the infection in the metaphyseal region and reaching the joint. Actually, it is a little bit catastrophic. It depends on early suspicion, and early diagnosis is the key point to gain a good function. And also, it's a balance between the virulence of the organism and the immunity of the patient. If the patient have morbidities like, for example, diabetic or immunocompromised liver and kidney disease, he will maybe end with as septicemia, for example.
Okay, thank you. Thanks a lot.
Thank you.
Thanks, sir.
Over to you, Dr. Vishnu, if there are questions from other panelists and speakers. So,
I think. Dr. Chinmay, sir.
On behalf of WC India chapter and secretary of the WC India, I thank all the esteemed Indian speakers as well as our guest speakers from overseas for this educative webinar and this on recent advances in musculoskeletal infections. We all have learned a lot, I think, from these webinars. And I thank all the faculties as well as the portfolio holders of the WOC. Like Dr. Arindam Banerjee was just left, but he has given a nice talk on introduction with the president of WOC International, Dr. Pitendra Sangaram. He is out overseas, so he cannot join. He's the editor of the WOC. Dr. Vishnu, I thank you for organizing this nice webinar and nice topics as well. And coordinating with all the speakers, Dr. Mustafa, Citak, Dr. Haesham, Elbasset, Dr. Menon, Dr. Vikas, Agashe, Dr. Umang, Agarwal, and all the Ortho TV guys, and especially Dr. Haesham for allowing us to hear our team on Ortho TV. And finally, Dr. WC International and different section of EPA, as well as the European Bone and Joint Society, etc. And all the members of the WC India, as well as all the viewers who has made this webinar successful. First, we graduate to the physical mechanics, PM, as well as workshops on different basic topics for aiding our target, reaching our target of reaching to more and more leading candidates and also doctors in Thank you all. Thanks. Good night.
Thank you, sir, and thank you, Aditya, for your extensive
Yeah.
time and effort, and thank you, Agashe, sir, and all the international faculty and the senior members. And this shows the interest in musculoskeletal infections, which is going to be a very definitive future for the postgraduates and everyone to take up this field. Thank you, everyone, and have a good
Thank
day.
you. Thank you.
Thank you, sir.
Thank you, everyone. Take care.
Have a good day.
Bye bye, everybody. Thanks
Thank
for
you,
your
sir.
attendance.
thank you.
Bye.